Good morning, everyone, and welcome to our monthly live broadcast of the peripheral live cases from Mount Sinai Hospital. A very happy new year to everyone. I, Vishal Kapoor, welcome you with my partner, Sardar Farhan, for another beautiful case from here at Mount Sinai. Before we go on to the lab, don't forget to log on to our website, ccclivecases.org, for our previous cases from peripheral interventions from the last few years, our evs.org for our endovascular summit, which happens every year. Hopefully this year we should be able to see each other in person, but if not, then we'll definitely have a virtual session for sure. So without further ado, I'll like PK. Good morning, PK.
Good morning, Vishal. Good morning, Sardar. Good morning, Dr. Kukar, Atul Kukar, who is virtual with us today, who is also the director of cardiology at Mount Sinai, Queens, and a very busy peripheral interventionalist. But I'd like to welcome you to Cath Lab 1 because Cath Lab 6 is under control, as we I should say under construction for the next 3 or 4 months. So we'll be out of these new spaces for the time being. But we have a very exciting case for you, all of you today, and I do want to emphasize that this is 2021, it's a new year, and what we're going to be doing different in peripheral interventions on our webcast is really come up with an agenda. Myself and Dr. Kapoor have been talking about sort of a curriculum in which we can set up more of a advanced curriculum for really complex cases and complex decision making. And in the highlight of that kind of theme for this year, we have chosen a very, very complex case. And really, we also want to emphasize the multidisciplinary approach to PAD, which is very important. And so keeping in step with that theme, we've asked one of our colleagues to join us today, who was a very good friend, Dr. Jit Rao from vascular surgery. As all of you know, have seen him many times working with us in live cases, and this helps us tremendously with all the complex cases we do. To my left here is Dr. Karthik Guja, our Assistant Director of Endovascular Services here. And then we have Raman Sharma, our current Endovascular Fellow, along with Sri Avadani. And our team, we have Chris, we have Elizabeth, we have Ray, our esteemed endovascular nurse practitioner. And we have, obviously, a great case. I'm going to kick it off to Raman to get it started, and then we'll get the discussion going.
All right. Good morning, everybody. So today we have quite a complex, a very interesting case. It was a transpedal approach for an SFA CTO intervention. This is a 77-year-old female. She has a past medical history of hypertension, hyperlipidemia, CAD. She has had multiple PCIs. Last was in 2010. Also has a AAA that had an endovascular repair back in November of 2019. Also a history of hypothyroidism. Her story originally began when she presented around July of 2020 with worsening debilitating claudication bilaterally, left greater than right. That was despite maximal medical therapy, and it was limited to just one block in Rutherford Grade III. At that time, she was on her full medical regimen with aspirin, Plavix, Cozar, hydrochlorothiazide, beta blocker, statin, Pletol, and still had her persistence of her symptoms. At the time, an arterial duplex had revealed a totally occluded SFA on the right, from the prox to distal, with patent infrapopliteal vessels with just mild atherosclerosis. The left showed a distal SFA lesion about greater than 75%, with similar infrapopliteal anatomy as compared to the right. ABIs at the time were both positive. Right was 0.64 and the left was 0.7. So at that previous intervention back in July, here we have her aortoiliac DSA, which is showing this patent aortoiliac endovascular repair with the two limbs going into the common iliacs. And this axis was taken by a left radial approach with a pigtail in the distal aorta. And hopefully this could be seen a little bit. This is just the runoff of the left. It's going pretty fast, but there is a lesion in the prox and then lesion in the distal with the same outflow vessel that we had appreciated on the ultrasound. And briefly, the case summary for the last time was, as I mentioned, a left radial and left PT axis, both with a 5/6 slender to rheumatoid sheath. lesion was crossed in a retrograde manner with the Spartacore wire with a Nivy cross catheter, and a silver hawk EXL directional atherectomy was performed to both lesions in the SFA, followed by a DCB of the SFA and the Zilver and the proximal. And these are the final still images of the angiograms. When we took a picture of the right, we'll take even more now, and we'll be able to show more. It showed a pretty long calcified CTO section of the prox to mid-distal SFA with patent 3-vessel runoff. Here we have the proximal and distal caps of the SFA CTO on the right. You see again, we'll be able to show this in even greater detail in just a moment. We see a definite nub in the proximal segment with another discrete re-entry point in the distal. And this is the runoff that was previously mentioned. You see the PT filling on the DSA on the right. Just given the timing of the actual images, you can take my word for it that the AT is also present.
Well, and we can show it on ultrasound.
Yeah, we'll show it too.
So thanks, Roman. That's a great presentation. So, what we really wanted to talk about today is really there's a big craze on pedal access and primary pedal access for intervention. And I know that myself, Dr. Rao, Dr. Guja, and our moderators, all of us do pedal access. And I wanted to spend a little time on appropriate, patient selection for these kind of cases. And, before we do it, I just want to talk about our logic. Our logic in this particular case is this is a patient who's got a long segment occluded SFA, has a bypass graft, has a AAA endograft, and now basically has claudication, not critical limb ischemia. She has a wonderful above knee target, calcified, but I'm sure it's surgically can be amenable, and Ajit will comment on that when I show you the pictures, and has 3-vessel runoff to the foot. So what we wanted to do was to approach this from a pedal first approach, because we really have no option. The antegrade approach has no option because there's not enough of a stump of the proximal SFA for me to put an antegrade sheath in. Up and over is impossible, just because of the nature of the AAA graft, which makes it very difficult. Probably in this case impossible. Number 3 would be a radial approach. Would probably leave me with not the optimal medical therapy or the optimal interventional therapy. I'm probably not going to be able to use a DCB. I'm probably not going to be able to use a drug-eluting stent. And probably I'm just going to be left with balloon angioplasty and a bare metal stent in a long SFA lesion, which is probably not ideal. So therefore, in this case, we decided to do pedal access. So, Vishal, I'm just going to ask Ajit here. Ajit, what are your thoughts, in terms of pedal access and how you choose and the general concept of pedal access? First, as you know, in the OBLs and in many interventional labs, especially in cardiology, and probably in surgery, you can comment on that. Pedal access has become something where it's almost routine. Let's get pedal access. Let's do everything through the pedal, and then let's send the patient home with a Band-Aid.
Sure.
What are your thoughts?
Yeah. Good morning, and thanks for having me here. I think with pedal access, like you were saying, really patient selection is really the most important factor to have a successful outcome. I think things you have to consider are anatomy. So does the patient have 1 vessel runoff? Do they have 2 or 3? Because the concern with 1 vessel runoff, if you access that, you could potentially compromise that, and you can make a patient acutely ischemic. So I think that's one very important consideration. In this case, this patient has 3 vessel runoff, so that's very favorable for pedal access. And then number 2, I think, is indication. So certainly, I think I'm a little more conservative. So patients that have critical limb ischemia, I think that's someone I would consider more heavily a pedal access. And then someone with very lifestyle limiting claudication, that's becoming
the young lady.
Yeah.
Mm-hmm.
So and then finally, I always think about what are my open options.
Mm-hmm.
So if I think pedal access isn't going to be successful, or they have 1 vessel runoff and I'm worried about compromising it, then the other option is, can I just do an open surgery? And so that's another thing that kind of plays into that.
So I guess the key point, and Vishal, don't let me just blabber on. Please interrupt me. Is that when you make these kind of decisions, and what my concern is that the cardiologists look at the pedal vasculature as a radial. There's a lot of people have told me that hey, we do radial all the time. Why can't we do pedal? And do the same thing? And my question is, I believe that in a vascular patient, the pedal vascular bed is much more diseased than the hand vascular bed. So even if you may have 3-vessel runoff, compromising one vessel, especially since we don't know the outcomes of the artery, and Raman has made a presentation on that, in terms of the distal outflow, I think that we should be very selective in who we choose. Obviously, guidelines haven't weighed in on it because there's not enough data on it, but it seems to be a trend more and more, and that's my concern. And before I ask Ajit to answer that, let's talk to Vishal and Atul and of course Karthik and see what their thoughts are. Vishal?
Yes, I think I completely agree with you. The biggest point or the factor we have is the long-term outcome data. I mean, we are getting accesses, radials, pedals, all the alternate access, but what's the long-term implications is the biggest question, especially in the runoff in patients who are actually presenting with CLI and critical limb ischemia. So you're absolutely right that choosing the right vessel and not jeopardizing it in the long term is what our goal is. So patient selection, I guess, becomes the biggest, and the anatomical description becomes the biggest limiting factor in this case. But I'd like to ask
But
Atul.
Vishal, the one question is what I'm specifically talking about is primary pedal access for therapy. I think getting pedal access to cross the lesion and working from above is pretty well established. I think everybody feels comfortable in the appropriate patient, even for a claudication, to do that. I'm talking about primary pedal with a 5-6 slender or above to go ahead and treat a claudication. That seems to be the controversy in today's day and age because everybody seems to want to do that. I understand it makes convenience for the patient. So I think for the audience, pedal access, I think we all know, is an incredibly important part of our armamentarium, but we're specifically talking about primary pedal access for intermittent claudication.
Yeah, I think that's actually a very good point because I mean, we have to first of all define the anatomy of what the vessel runoff is, and plus in claudications, picking the right vessel and intervention and the long-term outcome is what the biggest concern is. So like how we do, if we do radial access, we always initially, like we used to check for the ulnar patency, the Barbeau's test, make sure the the hand circulation is complete. Do we do that the same in the legs when you're digging claudication? I don't know, nobody I guess does it, but doing primary pedal without knowing the long-term outcomes, I'm not a big proponent of it as of now, unless somebody comes up with a long-term study to say claudication, primary pedal access, the adverse outcomes is pretty much negligible. So that's one important factor. I agree with you. How about you, Sardar?
I think, I mean, well described. The access in pedal is always going to be in jeopardy if the limb is going to be in jeopardy if this vessel goes down. We know from the radial access studies in coronary interventions that if you run it in a daily basis with accurate follow-up, with ultrasound follow-up, you find 6 to 14% of radial artery occlusions. In real life, in trials is of course less than that. It goes up to 4 or 5%. But an occlusion of a radial artery after an intervention always poses the patient to several limitations in his life, especially if he's right-handed and needs the right hand, and there is less mobility or less agility with the right hand. Similarly, we should treat the pedal access, and especially if we are doing treating patients just for the sake of life-limiting claudication or quality of life improvement. In this kind of access, in this kind of modality, I would be very cautious. Until now, there are no prospective studies with no thorough follow-up. There are only reports of pick and choose selected cases, retrospective design. Most of them reported that there were no occlusions or only minor occlusions, but they picked among 116 patients, only 42 patients where they followed those patients. We don't know what happened to the other patients. So I believe that if you run a thorough randomized clinical trial, you're going to find at least the same amount of tibial vessel occlusions after getting tibial access and putting a 6 French sheath in. And until we know this data, we should be very cautious and be very gentle with treating from pedal access.
Atul?
So I'm going to go back to what Dr. Rao was saying, and I think if you have a 3-vessel runoff, we're at the beginning of a mini revolution. And I think with 3-vessel runoff, it's about time we started studying the pedals. I think the access is great. I'm a radial interventionist coronary-wise, so obviously, PK, you're absolutely correct. I think we feel more comfortable going pedal as a radialist, but you're correct. There is a big difference in the vasculature and how it works, but it is still a loop And I think we need to get more involved. And if that means we need a trial, then we need to get on a trial, because I think this is a way to go. And if people are going to do this ad hoc in the outpatient labs, well, then it behooves us at an academic medical center to show and help them show that this is the right way to go if you do it safely. And Fredar mentioned, about the 8% radial artery occlusion rate. That's when we're using a 6 French sheath in the radial artery. But we're talking about 5, 6 slenders in the pedal. We can also talk about 4 French sheets in the pedal. We can talk about 2.9 French sheets in the pedal. We could do sheathless pedal, and that all of will make a difference in how the patency is and whether we get there.
Well, you can't do sheetless pedal. We're talking about pedal interventions. Pedal access, I think, is 100% is true, Atul. I agree with you. But when we talk about pedal interventions, you're not going to do them with a 2-3 slender or whatever 2-3 sheath. You're not going to do it with a 4 French sheath. And we're also talking about the fact that the outcomes in the coronaries are a lot different than the outcomes with the claudication. So I think it's important for me to push back on you and say that you're right. You may be in the mood of a revolution, but the point is the goals of the revolution are not defined. In the coronaries, you're talking about prevention of MIs, we're talking about mortality, we're talking about patency rates that are 90+% at 5 years with drug-eluting stents. You're talking about reduction in mortality with STEMIs. You're talking about reduction in bleeding complications and reduction in transfusion. So you have a lot of hard endpoints. With a claudication, even with the best data that's available with drug-coated therapy, you're only talking about a possible 60% primary patency with the longest drug-coated balloon that we have, and that too is registry data out to 5 years, actually out to 2 years with the impact long, and up to 5 years with very, very short lesions. So while I do agree with the enthusiasm of what you're saying, I think it's important to really compare marbles to marbles where this is not. I mean, this is a limb. This is a claudication. This is a patient who's probably going to have a coronary event before they lose the limb. This is a lifestyle limiting situation where we may potentially accelerate the process of going to critical limb ischemia if we're not careful in terms of trying to treat this claudication. And that's my pushback. And I think cardiologists as a whole are losing that because, yes, of course, the enthusiasm of the revolution is there, but I think we have to look at the goal of our therapy, and that's just my point. Karthik?
No, I was just about to say the point. I mean, I don't know why we are comparing radials and pedals. I mean, I'm the junior most in the room. I should say it doesn't make sense to me at all. Comparing radials and pedals is like comparing apples to oranges. The target organ when we're doing radials is the heart. The target organ when we are actually doing the pedals is actually the leg. It's like getting a distal coronary artery direct access to treat a proximal coronary artery lesion. We do retrograde access, we go retrograde and everything, but we still do the intervention from the antegrade side for coronaries because you're attaining a distal flow. When you're doing a pedal access, yes, you might be you can say, oh, I'm checking the pedal artery right after the intervention, but you're losing an artery. We
Potentially.
Yeah, couple of months ago, we were all crazy about angiosome theory. The whole point of angiosome theory was giving a direct supply to a wound. So you are taking let's say we take a PT axis or a DP axis, and the PT axis closes, and the patient develops, there's a potential of patient developing a plantar ulcer if the PT axis closes. If we all believe in angiosome theory, either you believe in angiosome theory or you go pedal axis. You can't argue on both. If you are closing a vessel, that means, as PK said, which I totally agree with it, you're accelerating the chances of that patient getting a critical limb sooner than later.
But we don't know that.
But we don't know that, Karthik.
No. We don't know that, but your target,
you're
getting access in your target organ, right?
The target
organ is our foot, right?
No, I mean, so right now we're talking like PK is talking more about claudication. Like now we're overlapping CLI with claudication.
I know, Vishal,
so
but when you're doing claudicants, what are you achieving? Not just pain relief, right? You're trying to make sure that the patient doesn't progress into the Rutherford class or a Fontaine class into a critical.
The one thing we know is that claudicants very rarely progress to CLI.
Exactly. Right? There's a 4% chance that the claudican progresses.
That's my pushback on what Atul said, because I really believe, and Ajit, I know we've been yapping. What are your thoughts? Hold on, guys. Let's get a different perspective.
No, all great points. Just a couple of things that I want to add. So, I'd be very hesitant to compare the radial artery access to pedal access, because number one, even when a radial artery thromboses after access, which actually doesn't happen very infrequently since we get called about that, usually the ulnar is sufficient to provide collateralization to the hand, and maybe they need a couple weeks of anticoagulation, but they'll be fine. When a pedal axis thromboses, that can mean whether they could potentially lose their foot, whether that's in the immediate period or even 2 or 3 years later when that's the only pedal vessel that's left. So I definitely think there's even though we treat them similarly in terms of giving nitroglycerin or whatnot, the outcomes can be different.
Yep.
To echo kind of what everyone's saying, I think definitely treating claudicants is very controversial because we don't know what the long-term effects are. Even though they don't progress, if we treat them, maybe that increases their chances of progressing in the long term in next couple of years. And so that's why I think we need to have a really high threshold for pedal access. And certainly not the first thing I would choose. In this case, we don't really have many options here, like we discussed.
And honestly, I agree with what you're saying, but I just want to conclude before we start. I know it's an important discussion. Like the points, and I want a lot of feedback from the audience when you guys see this, and ladies, is that the endpoints are what's important. And in coronary, you have a completely different endpoint and outcomes for the patient when you're treating coronary artery disease and ischemic heart disease and acute MIs. In claudicant, it's completely a different endpoint. The actual mortality endpoints are really associated with the heart, not with the limb. So that is why I'm a big proponent of pushing the field forward. But I think we need to push the field forward with data, not just do it because we can do it. And we can do a lot of great things. It doesn't always make sense. Okay. So with that, I'm going to ask Karthik to demonstrate how to get pedal access with the ultrasound. And Ajit, you can talk a little bit about the vessel choice while he starts.
Yeah, sure.
So. I don't know how we can.
Yeah, can you put on the ultrasound, please?
So Sardar, Vishal, and Atu, how do you guys choose your vessels when you have 3-vessel runoff? I mean, of course, clearly either it's PT or AT, but any thoughts?
I go with the AT. I go with AT first as the primary access point. If they're both open, I will take the AT because I think the closure is easier.
And Vishal?
The compression is easier.
Yeah, I mean, we scan the whole leg in its entirety to see what's the patency of one vessel versus the other, the calcification, the luminal size. If I think the AT is bigger with less calcification and no lesion, then I'll go AT. But if I think PT is the bigger vessel, which could take my 4.5 or a 5.6 slender with calcification, I would probably take the PT. Because closing AT is easier than PT, but most of the times it's because of the small vessel, you can close either way. So for me, it's about the sizing, the calcification, the patency, any associated lesions is what's my limiting factor.
So
I agree with Vishal. I would try as much as possible to get the access over a bony structure.
Right.
This makes the dorsalis pedis actually a very appealing site, but also the PT in the foot is a good access. Peroneal access I would only obtain if it's the only remaining vessel for a CLI case, but otherwise I would defer from that. Yeah, that's essentially my choice.
Yeah, no, I agree with all those points. Just to reiterate some things, I think choosing a healthy access point is important, because you don't want to struggle with pedal access because that, I think, increases your chances of having thrombosing it and not being able to obtain it. So if the AT and PT were equivalent, then I would go for the healthier option, assuming they both feed the foot. Mm-hmm. If one is dominant, let's say, in this case, the 18 was the dominant runoff and the PT was not, then I would choose the PT actually, because if I compromise that, at least, I haven't ruined the dominant runoff to the foot, assuming I think it's healthy enough to get access.
The other thing also is the entry point of the sheath, and I think it's important to look at the angle of entry. If you're doing pedal first for therapy, like in this particular case, you want to have a long straight segment and not have any angulation as you go in. So if you're going to introduce drug-coated balloons, if you're going to introduce crossing devices, if you're going to introduce glide wires and glide catheters, you obviously are going to have, you are obviously going to need a nice angle. So here the posterior tibial artery gives you a nice angle, but the anterior tibial artery, because of the bone and how the artery is going to angle up, I think it's better to go with the PT. That's why we chose the PT. So Karthik, you want to go ahead and do it? So,
so as PK said, I think PK is already decided. The boss decided, so we have to go with the PT. But it looks like the vessel.
Well, that's the fifth factor. I agree.
Factor number 5. Yeah.
Me and Vishal and Sardar still want to be in the program, so
No, come on.
so we'll go with it. But my decision to go with PT was PT is a larger vessel here. If you see,
Correct.
PT is almost like a 4.0 vessel.
Yep.
And if you actually look at it, this is the dorsalis DP. DP is almost like a 3.0, 3.5, and the calcification is also much higher. If you see, there's a circumferential calcification right here. A lot of plaque also in the DP as I track the DP down to the AT. So normally how I do it is I always track the vessel down up, like to the vessel of the calf, the side of calf. So once I keep tracking, because the sheet tip is somewhere going to be around here, and you see there's a big chunk of plaque there, right there, which is probably not a good idea. So if you actually track the PT down, the PT is there is calcification, but it looks more like it's more adventitial calcium here. And the way I look at it is Mickey Mouse sign. I look for Mickey Mouse sign, 2 veins for every arteries. So what I do is to get the access, the best way to do it is compress. When you compress here, so all the veins get compressed and only the artery stays open, like you see here. So that's the vein. So these are the 2 veins right here, right? And when we compress, both the veins get compressed and only the artery stays open. And this is a good spot to get. Yes, go ahead, Vishnu.
Right. No, Karthik, keep going. No, the only caveat is sometimes if you have a SFA CTOs, because the vessels are so underfilled, you can underestimate the size of the lumen of the vessel, number one. And also the arteries also become compressible. So if they have no calcification, especially below the knee because of the underfilled vessel, just for interventionalists to keep a thought process, if you're able to compress, because of these vessels so distally down, you will be able to also compress the arteries. So don't get fooled by the compression, but definitely you're right. We have to. That's one of the differentiating factors.
So another question might be also important to mention is ultrasound the way to go, or I think Dr. Krishna will have a different opinion to that.
No. Listen, I'm a lot older than everybody in this room. I actually have the freedom to say that. But I can tell you that I was not trained in ultrasound, although I'm getting better at it. I've learned from Ajit and my colleagues here that 100% I think ultrasound is the way to go. And if you're getting pedal access, you can get pedal access because myself, I know my colleagues in Europe, a lot of us do it with just angiogram. I think multiple reasons. 1, reduction in dye. 2 is less radiation to the patient as well as yourself. And 3 is great evaluation of the vessel, as you just saw. I can't do that with an angiogram. I mean, to me, I can get into a vessel, but I think all these things that Vishal and Karthik so nicely pointed out, and Ajit, I think clearly show this. Ajit, do you do anything different in terms of your technique?
No, I do. This is pretty much what I do. And once you guys get access, do you give any medications or?
Yep.
Okay.
Yeah.
Raman, why don't you talk a little bit about our cocktail, what we do?
So we use kind of the same medication we'll use for the radial cocktail, nitroglycerin, verapamil, things like that. Anticoagulation is obviously a part of it, but we usually wait until we decide about what the our final sheets are in. But a couple 100 milligrams of nitroglycerin from another sheath, which currently what we have is some 5 French on the left CFA, as well as some verapamil, heart rate, and
it looks like
ejection fraction permitting.
Let's look at the vein.
Yeah, but in terms of technique, I definitely use ultrasound. Even for the femorals, I'm pretty big advocate on using ultrasound, but especially for pedal sticks, I think it's important. You don't want to. You really want to see your needle go into the artery and pick a healthy segment.
So, I totally agree with that. I'm sorry, but I totally agree with all these points. But until now, I believe that the biggest data set published so far with regards to pedal access, the methodology of obtaining access was described as angiographically guided. This is the data from Leipzig from Dr. Schmidt. And only smaller reports were done with the ultrasound. I also believe that ultrasound is the future for getting pedal access in.
I honestly don't think it's the future. I think it's the present, and I think it should be the standard of care. I really believe that. I mean, me and myself and Andre and all of, like I said, the older gang has always done it differently, but that doesn't mean it's right. I mean, I think we have to change. I think Atul's point of being a radial interventionalist is very important because you have a lot of different tool sets that we can use. So right now we're just going to give the verapamil. And Ajit, can you talk about? Yes.
Can I ask a quick question before you guys
Sure.
pass on this point? So just a few quick things. I think, Guja is obviously very good at ultrasound. The pictures were beautiful. It demonstrated clearly why ultrasound is the way to go. I use ultrasound 100% for radial and femoral axis, period, across the board. I never blindly stick. But two things. One is this is a 17 megahertz probe. I think it's important for the audience to know that, right? This is a hockey stick you were using.
Yes, it is the hockey
I
stick.
used a hockey stick.
No, don't put that in.
And this makes it much easier to
go with
do
the
than
V18.
using your femoral transducer or another transducer, which is much larger. So I think the
V18,
17
guys.
megahertz hockey stick is the way to
Can
go.
I flush? Can I flush it?
Yeah, I think it's
V18?
absolutely right. Getting the right device and the right equipment is very important for your success. So Atul makes perfect sense. I mean, if you have to be a good access site, first thing to do is invest in your device and your stuff. So getting a hockey stick, Atul, will make a success rate, single stick, anterior wall stick, everything you can achieve with ease and with proficiency much better than transforming your other probes, essentially.
So Ajit, what do you do now? Go ahead, Atul. I'm
The
sorry.
other important thing is as soon as you got access, I noticed, right away you moved the table and immediately you went to fluoro, which is obviously the right thing to do. We may have been talking too much for the audience to see that. So as soon as you get the access, you went to fluoro to see how the wire behaved in the vessel rather than just feel only. So you want to see if the wire buckled at all. You want to see anything else.
Can you kick the pedal over?
Beautiful. We see the wire up in the upper shin already.
Right. So
That's one of the things right away.
And the other thing that we do that I'm a firm believer in is doing crossing with the lowest profile that I possibly can. So what I did here is I just went up with a V18. Looks like we're in the vein, Chief.
Vein.
Yeah, that's what I thought. It looked like we were in the vein. That's what I really felt. I felt like we were in the vein. All right, so we have the vein now. So we're gonna you see, guys, even ultrasound you can get in the vein. I feel validated. Ultrasound, please.
So I think that's another important point of using fluoro is just to track your wire to see if you're in the vein or the artery. So.
Well, I mean, usually we give dye, but we thought with the ultrasound that it wasn't necessary to give dye, but clearly, I mean, that went into the vein. So now we're going to go ahead and try with the artery, but the idea I think is important. So now the couple of things here while we do this, just to talk a little bit about the probe and everything. Ajit, in terms of common, in terms of
the iliac.
What happened?
Pressure. Where is it coming from? She's asking.
Yeah, you got to keep an eye on the pressure waveform. Oh, that's from the knife side, yeah.
Let me ask PK and everybody on the panel. I mean, I know we're doing pedal because of this AAA. What would you think? I know, and we have limitations from radials, the balloons, the stents, especially distal SFA if it's a tall person. How about doing alternate access, brachial, axillary? Remember, nowadays people are doing a lot of impellas and ECMOs through the axillary brachial system as well. And those are large bore sheets and they manage it decently well. Of course, long-term data is pending. We don't know. It's all random observations.
Get going.
So what's your thought on using brachial or an axillary in this case, especially if you're CTO and you need more support, as another strategy? Anybody would think about that?
I still think that, Ajit, I mean, why don't you comment on that, brachial or axillary?
Yeah, I mean, I think radial over the two. If I had the choice to choose between the two, I'd still pick radial. If I had the length, because brachial, if you get a hematoma or axillary hematoma, that's a surgical emergency. And also for radial artery access, as you guys know, we have like TR bands and things like that, which can manage the access site afterwards. So I definitely have a higher threshold to access those vessels, unless you don't have any other options. Especially for someone with claudication, I probably wouldn't do brachial or axillary.
Yeah, and I think those are good points. And I think one thing we didn't talk about here was distal femoral access. Right, we could have, but so if we're going to play the film here for you, and when you play the film, you'll see that the distal femoral might have been another target that we could have talked about. But what we felt was it was heavily calcified. And show me the angiogram, guys, as Dr. Guja just goes in. I just want to show you the angiogram. As you see, the distal femoral comes up here. See, we could possibly stick them, but it's very calcified and very diseased. So part of that is just doing the same thing where what I wanted to do is go ahead, just push the wire up. Let's see now. This looks like the artery. Let's see how it behaves. So I think, yeah, this is, let's see now. Let's see if it goes medial to the, and it's important to understand this looks like another vein. Let's give dye. Hold on.
Yeah.
We'll just give a little dye. To me, the distal femoral access is got to be a healthier vessel, right?
Right.
So that's the thing. No, this is okay. I think you're okay here. Just go up, see if it hits the.
No,
So while we're talking about the brachial, so
that's fine.
I'm anti-brachial. I think it's because I've seen the complications, unfortunately.
Right.
So I
Yep, this is
almost
it.
never
This is the
go
artery.
brachial.
Did you inject? Or?
Yeah, there it comes. See, it's the artery.
And I think
You're in the artery now.
The
That's the artery.
axillary artery.
Okay, take
I
out
think
the other
you have
sheet.
to really be an expert to get into, and I think the brachial plexus injury risk is not worth it for, like you said, patient
Right.
selection.
For claudication.
Shock,
But I,
things of
but
that
I,
nature.
but I think it's important, guys, and I wanted to talk to Ajit about the distal femoral. I mean, I think in this case, the problem with the distal femoral is we could have used it to cross, but I think you're going to end up where you're going to be in a very diseased plane getting in. It's obviously less comfortable for the patient because they have to frog dig their legs and all that.
Yeah.
But I think that's important.
Yeah. And I think the other
All right, you got the
other
issue
issues, you need some running room.
No, I wouldn't
And when
give
you
any more.
access
She-
the
she-
distal femoral, especially if you don't find a nice kind of channel to go into immediately, you can really struggle with it. You might not be able to
good.
make much progress.
You
So
pulled
I
out
think
the other
running
one?
room is important.
You're putting pressure.
You know, same reason why we didn't do an integrate in this
Yeah, but
in this
still,
situation.
it's
Just
an
as
angiomax.
there's not much
Laura?
running room to get to cross this lesion.
All right, let's wait. Let's get up. This is what? This is
I
V18.
got it. Go.
And then
Show me.
in terms of your pedal access, we were discussing this a little bit before, but where in relation to the ankle or the foot, where exactly are you accessing, and do you have any rationale for that?
Yeah. What do you think about that, Ajit?
Yeah, I mean,
Okay.
for me,
now give
I think
now give me-
finding a healthy segment is the most
me
important.
the,
So, whether that's in the foot or higher up,
V18.
No, fine
you
cross.
just want to find a
I mean, not
healthy
fine cross.
segment.
Well,
Personally,
when
I
overnight,
prefer to
right?
go above the ankle because I think the vessel is generally a little bit bigger.
Right.
And also, in terms of managing the access afterwards, which I'm sure we'll talk about, you can put in a balloon and do prolonged inflation. You can hold pressure. You can put a TR band. So I think it gives you more options there. So I personally prefer to go more proximal if I have the choice.
Me too. And here, so here what we've done, guys, rather than put a sheath in, because we don't want to disrupt this vessel unless we've truly crossed. What I've done is I've gone ahead and we've given our cocktail, and now we're taking the O&A Trailblazer all the way up. And then once we take the Trailblazer all the way up, I'm going to have a Karthik to push it, and then put hold pressure on the vein. We're just going to go ahead. And what are your wires, Ajit? What wires do you use? Go
Yeah,
Flora, bro.
Yeah, this I do something very similar to you, where you kind of escalate, the sheet size and the wires. So I definitely start with actually I do start with a V18 and
Right.
018 quick cross catheter initially because I think
Push
that's
the quick cross up.
this. Besides the 014 system, it's a pretty atraumatic, and I think it lowers your risk of having a injury to the access vessel.
Well-
So if that doesn't work though, then I switch to I put in a sheath, whether that's a 4 or 5 French
Yep.
slender sheath, and then I go with a 035 system, probably like a glide
Give me a
wire
Confianza.
and a quick cross catheter at that point.
Yeah.
So I think.
I think we're obviously hitting this garbage. I think we're hitting the plaque here. We need to penetrate the plaque. So I'm going to go with an 014 wire because I think we can get through this. If not, then I'm going to do exactly what you said, Ajit, is escalate it up. But I think clearly at this case, I think at this stage we're just going to try to wire through this. And you can see there's that chunk of calcium there, which I think if we get through it, I think we're going to be in good shape. Flora?
Yeah, but I definitely
So
think
right now
V18
you're
is a good.
sheathless, right?
Yep. What were you saying, Ajit?
I
Flora?
definitely think a V18 is definitely a good wire in this case because it's
Okay. See if we're able to find
crossed a
plane.
lot of lesions with it
Yep.
quite easily.
I'm just trying to see whether I can find a better plane to get through, because there you go.
And I also find that a lot of times, the
Bracket
other
now?
time we go from below is obviously when we can't cross from above,
Uh-huh.
and a lot of times it's just easier to cross from below because you're not dealing with that maybe proximal
Okay.
cap, and if you end up in a dissection plane from above, you don't end up in that plane coming from below. So
Yep. I'm gonna
definitely think it's easier to
yeah.
cross lesions as well.
Yep. So I think you're right. Give me back a new V18, guys.
And I think one of the important factors, which probably we'll discuss down the lane as the case progresses, is what happens if, I mean, remember in CTOs, we have a tendency of going long
V18.
subintimal. So what happens when we reach that proximal ostial segment, and now we are in the subintimal plane, getting back into the CFA, how far do you go up? What are the strategies? Because that's one of the limiting factors in cases. You might be able to loop and go all the way up. But the biggest question is re-entry into it, and how far do you go up into the CFA and not compromise the profunda?
5-6 slender,
questions. Please. I think that's one of the biggest factors for the success of any case, especially in these cases like this.
So with this much calcium, what we're going to do now is we're going to go ahead and put a V18 back up, and we're going to go with a 5-6 slender, and we're going to go ahead and escalate this, and then we're going to put in a
If you're putting a 5-6 slender, you cannot put a V18.
Why not?
5-6 slender doesn't go over a V18. Why?
Why not?
Because it's an 014.
Yeah, I would to answer that, start answering that question. I'd be hesitant to really propagate that dissection plane up approximately. So, if you're in a, once you basically cross back into where the artery is open again, I think it's worth shooting an angiogram, making sure you're intraluminal and not in a dissection plane, because last thing you want to do is dissect your common, compromise the profunda.
Well, yeah, and I think that's what's important here to say where we stop and where we don't stop, right? And I think that's part of it. So I'm going to walk this out now. I'm going to go with a 5-6 slender. I need a Terumo Navicross now. And now we're going to go with 035 wires from below. And the reason we decided to go with the 5-6 slender, Ajit, is because obviously we're going to have a lot of prolapse of the wires we're pushing. So we need to have a support catheter close by. We need to make a nick, guys, to have a close by.
Not necessarily.
So Raman, while we're doing this and working, can you present some of the data that you've accumulated, and we can have a discussion on what data is available for peripheral access?
Yeah. All right. Here's the Navicross.
Okay.
We can put the slides back up, please.
No.
Okay.
The slender.
Perfect. Go.
We can put the slides back
Put
up,
the slides up, please. Okay. Walk out the dilator. Angiomax on, yeah. You didn't give it? Bolus? I thought you gave it.
Okay. So let's see. Yeah. So this is pretty much we've all caught up here.
No. Yeah, you can.
So we've had a lot of these conversations already, but I guess just to reiterate a few of the key points and some other salient features. So we'll start by just trying to quickly to summarize, when should we consider alternative access for endovascular interventions? Obviously, extreme iliac tortuosity, although it's not a precluding factor, there certainly are times where iliac tortuosity proves to be just very, very challenging. Hostile groins with previous cut downs and previous injuries, active infections would make you want to avoid common femoral access. And then, as we see in our case, any prior common iliac or distal aortic interventions, whether it be common iliac artery stents, AAA endovascular repair, or an aortobifem bypass, would also prevent you from doing our traditional up and over technique. The need for extra support for excessive calcific disease sometimes could also prove to require you to get some alternative access. And then there's a particular subset of patients that are just extraordinarily tall, especially in this diabetic pandemic, where a lot of patients will have just predominantly infrapopliteal and tibial disease. Sometimes a matter of just the device length becomes an issue. Infrequent, but not impossible. So this is just a quick, a couple of illustrations of previous cases here. Iliac tortuosity, like we see in the top left, again, not a precluding factor, but certainly would not make a very challenging, long calcified CTO a desirable, upfront approach. Then you see our common iliac stents on the bottom left, the aortobifem bypass in the middle, and then a case very similar to ours with the endovascular repair on the bottom right. And then we finally have the CTOP classification, which sometimes you'll see that a couple of the transpedal approaches will just, because of how the distal cap is shaped from the pedal approach to traverse it retrograde, will actually be favorable given the cap anatomy from the retrograde approach. Other ideas include that the proximal cap tends to be more calcified than the distal, sometimes making penetration of the cap from a retrograde approach, sometimes just more simpler. So again, here are some of the ones that we had mentioned: transradial, antegrade, CFA, SFA, direct SFA, popliteal, transpedal. We spoke about the transradial a lot the past couple live cases, so we won't dive too deeply in that. And we spoke about it today quite a bit. We'll start by talking about antegrade, CFA, SFA, alternative access. There's quite an amount of pros and cons associated with both. Cons of the alternative access with CFA or SFA access in the antegrade fashion is, there's clearly an increased use of radiation here. Sometimes also, if when getting the direct antegrade CFA access, a large pannus can sometimes be quite challenging to navigate through. And sometimes wiring directly into the SFA as opposed to the profunda may sometimes prove to be a little bit of a challenge depending on where the access point is and the bifurcation of the profunda femoris and the SFA. And then another important con to keep in the back of your mind is that there's no actually any approved closure devices for a direct SFA stick in the US. So all the closure devices that would be used would all be used off-label. But again, a major pro here is that you would be able to accommodate a large sheath if you do need to, depending on what your treatment strategy is. You'll have the support you would also need. But finally, you'll also be able to avoid any aortic iliac disease that may be precluding you from going your traditional up and over route. But an important point here is that, as you mentioned earlier, the reason why we can't do it in this particular case is because of the fact that the length of your sheath would have to have at least some room. Typically, we'll go with a 25 centimeter sheath from an antegrade fashion, so you'll have some room to actually land your sheath in the native vessel prior to a more distal occlusion. Direct SFA retrograde access, we spoke about that and why we couldn't do it actually in this case. Again, a major con to think about is the risk of vascular complications. In addition to that, there's no real closure device, obviously, for the. There's no real closure device for the manual direct SFA action besides a manual compression or balloon tamponade. And then finally, also the main way that we typically get direct SFA access in this lab is just by ultrasound. By X-ray. Although some practices do also use ultrasound as the primary way for access to the direct SFA. Another pro for this, though, is that given the fact that you're not planning on putting in a sheath, you're able to use, just as we are kind of using or began to use in the transpedal approach, just a catheter-assisted or balloon-assisted insertion. So a sheathless small access site is what typically you'll be using. And also, as illustrated in the image on the right, if you're having a very long CTO ISR segment that involves ascent and you decide to do a direct SFA axis, your traversing lesion length would be less if you go from a direct SFA axis point in the retrograde approach to then eventually externalize and then cross further in an integrated approach from another axis point. Finally, transpedal axis, what we're talking about today. Vascular complications is kind of what the main question is. What are they? Do we really know what they are? A feared one, obviously, with compartment syndrome, which is not really one that we have in a different circumstance. Radiation, depending on how we choose to actually get the access. As sort of mentioned, one of the biggest trials we have, transpedal access was only obtained via angiography. Again, then the fact that these are smaller caliber vessels, we are kind of limited by our sheath size, which can safely be inserted, and thereby also limiting the devices that we can use. And finally, again, as we all mentioned, these patients are not, whether you choose them for just simply claudication, if we choose to do CLI patients, pre-existing tibial disease may truly be a limiting factor here as far as selecting the singular outflow runoff. But important pros to consider, again, you'll have increased support. An interesting technique that can be provided with the retrograde transpedal axis is you have both the option to do both retrograde crossing as well as complete revascularization. Now, whether or not that's what we are recommending, I think is a different question, but you have the option to both proceed with a crossing and exchange, or complete revascularization. Another, I mean, you can't just similar to the radial procedures, you can't disregard the fact that patients are more comfortable. They also have earlier ambulation. And similar to the direct SFA access, the fact is that you'll also be having, in some of the approaches, especially if you're just doing a crossing and a retrograde cross and exchange, you'll be able to have a ceaseless small access site. But this is not for revascularization, simply crossing and exchanging. So
let's stop there for a second because we're in a technical aspect of the case and I want to get some advice. So you saw that we transferred all the way up to the loop. We're having trouble seeing up top because of the graft. So the audience can see here where we are at the distal cap, and I'm being really careful because I don't want to dissect into the common femoral. And to the audience, I think this is very important because you can push the loop up and enter at the level of the proximal common femoral, but are you really doing the patient a service? Because then what's going to happen is you're going to now go ahead and compromise the profunda either with the balloon. If the flap goes this way, you may close the profunda, or you may create a dissection. So the idea here is to cross at the cap, and that's very difficult, as you can see, because we have this. So we have a 5/6 slender. I'm going to do external ultrasound now to try to see whether we can see where our wire and catheter is. So I'm going to change this to a confianza wire. Can I get a confianza wire, Ray? Yep. So I'm going to change this to a confianza wire. So I've broken the distal cap. I've looped all the way up. I'm at the distal cap, and now the question is whether we change. Ajit, anything you would do different here now?
Yeah, I mean,
take the wire out.
Yeah, this is certainly a tough situation from pedal access. You know, when you're coming from above, I think you have more options, whether that's an outback or trying to re-enter in a different area. But yeah, I think checking with an ultrasound can certainly help, and trying to find a different dissection plane to pop in, and kind of going more distal and coming back up. But really, it's about trying to
pull back a little?
pop through that dissection plane, and
right here.
preferably in the SFA where it comes back to avoid propagating anything.
Well, the problem here is we don't see the the common femoral at all. He's got the.
I mean, the only other thing to consider is like if we had radial artery access or something, we could put our catheter right into the distal, iliac artery, so potentially take better pictures. But it's obviously hard to do from ultrasound.
The only question is, let's do.
Do we prep the radial?
Well, I don't want to prep the radial. I think we'll be okay here. Let's try to let's go a little bit more dye here. So any suggestions from Atul or from you guys up there?
Yeah, I mean, you're absolutely right. It's just the visualization of where our CFA reconstitutes will probably guide us to see how far we're away from the lumen and what other technique we might have to use to, re-enter it. But yeah, I mean, we have to have a little bit more better view of how it looks. Ultrasound will definitely help, like Ajit said, but I guess a little bit of angiographic support might. Well,
the problem is, for whatever reason, they put it at 1100 psi. Can you move it so I can just see it for 1 second here? Let me just do let's just see whether we see it via, because when you put it under 600 psi, you're not going to see anything. See, on the 1100 psi, you'll see something. So you can see here we're above. So I'm going to pull back now, right? I'm going to redirect here. See, so we've created a big plane in another angle. So what we have to do is come down and find another plane, which is common. This does happen. Let's try over here and see. And the only way you're going to be able to do it is by trying to find a plane where it behaves different. Huh?
Much below. Start a new plane down there.
Yeah, well, it shouldn't matter.
Where the calcium is.
Oh, let's see. Nope. There you go. Nope, definitely not that.
Yeah. So as we've been talking about a little bit, one of the challenges is that this patient obviously has a aortic stent graft, which makes it hard to go up and over. Speak a little bit about that. As we know, the aortic stent grafts raise the normal aortic bifurcation, which is why it's so hard to go up and over. And
give me a Terumo.
And so there's some advanced techniques you can do to kind of help you, but certainly in this case, I wouldn't recommend that, because the last thing you want to do is dislodge your aortic stent graft and bring it down. There is one EVAR, one device where the native bifurcation is preserved, the AFX device. But even then, that one's a little different because the stents are actually on the inside of the fabric, so you can actually go through between the stent and the fabric, and it can also be challenging. So really, there's no good options once there's a EVAR in place.
So what about the other graph, the Endologics graph that you had? AFX. Oh, is that what you said? Yeah.
Yeah. The AFX is the only one where the native bifurcation is preserved, so it's definitely easier to go up and over. But like I said, the wire forms are on the inside, so you can actually go through them and get kind of stuck in them, and still not always easy. So.
Yeah. Well, the question is, would you use a reentry device here?
Yeah. So I mean, that's a very good point. I mean, even though they say, if we had some lumen, we could use it, but here you can try to use a re-entry device, maybe like a low caliber NTR, to see if you can enter the intraluminal segment proximally.
Well, we did that. We did that live in Link last year. Remember?
Right.
Or 2 years ago, whenever we did it. So that might be something we could think about. I'm just trying to find another plane here, and we're not able to find another plane. You can see here we're next to it. No, I wouldn't push up, Karthik.
Yeah, I'm not pushing up. I'm just holding it.
Yeah, give me a Terumo.
Right here.
What is it called? Different wire?
The gold.
The Terumo gold.
The only question is, have we perfed into the vein? Because you can see I'm getting a lot of blood.
Yeah.
And but it looks arterial though.
Yeah.
It looks very arterial.
Yeah, sometimes the plane becomes too big enough that you might have some antegrade arterial flow even into the dissection section. So
there's the catheter, right?
Yeah.
What is that right there?
No, that's a dissection plane.
That's the plane. So we're in the artery.
Yeah, we are definitely in the artery. That's a plane we created. So.
Okay, good. that's a good sign. So can you show the ultrasound as well, guys?
Flip over to the ultrasound?
Yeah, can we see the ultrasound, please?
Okay, so that's the central calcium and the plane we dissected right there. And that's your main vessel, and that goes into.
Am I in the common femoral here, Karthik?
No, you're not.
Not yet.
No?
Not yet.
Well, it looks angiographically I may be. That's what I'm asking.
You're in the nub. You're in the small nub of the SFA.
I'm in the nub of the SFA or the common femoral?
So this is your common femoral.
So I'm in the nub. Am I in the nub of the SFA?
And this is your SFA right here.
So am I in the nub of the SFA?
Yes, you are.
Good. So
I mean, in the plane.
Okay, good.
Not in the SFA. That's your catheter.
I also think if we had, in this case, obviously it's not possible. But if we were able to go up and over, having access from antegrade and being able to meet the catheters in the middle, or trying to balloon and create a channel when we know we're intimal from a up and over may help in these cases.
You can enter it if you want here.
Okay, where am I now? Give me a torque.
You're right on the vessel.
I'm on top of the vessel?
Right on top of the vessel.
What other techniques do you guys have for re-entering?
Well, one of the things we could do here is use an anterior catheter, which is a low profile, rather than take up a outback all the way there, right? We could do an anterior and try to poke in, which we did live, like I said. We could try that.
So that's your catheter, Piggy.
Yeah.
See that?
Uh-huh.
That's your catheter.
The only question is...
You are as good as a vascular tech. Your ultrasound imaging is excellent.
So you see that? That's your junction. So you're in a plane. You see that wire coming in?
Yes, sir.
Now you're going into common femoral.
Yep, I know. I'm backing off.
You're dissecting into common femoral.
Okay.
So thank you, Atul. So this is a good spot to enter. You're actually right in the nub.
You can probably pull back just a touch and enter just distal to the common femoral origins.
So if you actually see the ultrasound, that's where the junction is.
The 21?
The SFA comes into the common femoral. There's a big chunk of plaque there, calcified plaque, and the catheter is sitting right in that plaque. So if you just enter it this way, you can actually probably do it on ultrasound. Actually.
So I'm just going to try to do it without so the catheter is what, superior or inferior?
Inferior.
So we have now am I pointing superior?
Yeah, now you're pointing superior.
Okay, now give me the Ashtato, please.
This is just like you put
give me the confianza then.
RF catheter in a vein. You see the,
you see the
catheter right there.
Yeah, that's a... I don't use ultrasound often, but I definitely think one of the utilities is what you're doing now, where you can actually see where your catheter is and which way you need to...
we did this live, I think this is the reason
all you have to do is just poke it and then poke it anteriorly or inferiorly. You'll just go to the main
can I have the
vessel.
confianza since we don't have the Ashtato?
Right.
So if you actually take a picture, now do you want to say?
No, I don't want to take a picture. Yeah, we're good. Let's just go right now. All right. Let's go here. So am I still pointing in the direction I'm supposed to be pointing or no?
You're okay. You just have to go anterior. That's it.
Yep. So am I, if I poke now, am I good?
Yep, you're great.
Okay, let's say.
You'll go right into the vessel.
All right. So this is kind of the use of a hybrid ultrasound. And the whole idea is everybody can see I don't want to dissect into the common femoral. Dr. Rao can do a bypass if need be in this patient.
So if you
What
look
happened
at the
now?
ultrasound, so you see the wire is coming right at the junction.
Am I good now?
You're good here,
You're
but you have to go
facing
anterior.
posteriorly. Yeah, exactly.
You're
facing
going
posterior.
posteriorly. You're going towards the profunda. You have to go towards the SFA. So turn it up. If you make it, turn it anteriorly.
How's this now?
No, still posterior.
How's this now?
Still posterior.
Well, then I got to get another plane. How's this
Yeah,
now?
that's anterior.
Okay,
This
good.
is good. This is a good plane.
Okay. Am I in the vessel?
You're actually dissecting the common femoral.
Okay. No problem. I need a better wire, guys. Can I have my Estado, please?
NTR is very good, PK, right here. You might just pop in with NTR.
No, we're gonna get an NTR. I don't know whether it. How's that? That should be good.
No,
Still
you're in the plane.
Still in the inferior, still in the plane.
I think you might just have to pull back your catheter a little bit because that will
that's
give you a
good.
bit more.
That's good, but you are still in a plane. Like you're right at the junction.
Okay.
It's a pretty big plane, PK. So the vessel is like floating in the plane. So
Yeah, I think in these situations, having an angled catheter and even an angled wire is key because you're really trying to pop right through that dissection plane.
Yeah, I'm just trying to angle my catheter here.
your catheter went into the common
How's this?
femoral. You're already in the common femoral. So
With what?
with your catheter, you're a little bit too deep. Right
That's
there.
what I'm saying. You might have to pull your catheter back a little bit
Catheter
because
back a
it's
little bit.
selectively engaged into the CFA per the ultrasound. So I would probably just pull it back and try to NTR it because the lumen has become too big now. So
Do you?
Go ahead, Ajit.
I was just gonna ask and in terms of other things that we can think about, would you ever use IVUS in these scenarios? Do you think that would help in this case?
But the
or-
problem with IVUS, you have no directionality. We've tried IVUS.
I mean, you can do Pioneer.
Pioneer.
Yeah, pretty much the same.
Where's the wire now?
Good direction, but again, you're in a plane. It's a pretty big plane you
All right.
created. So,
So get us the NTR, guys.
like if you see in a short axis, it's floating. The
Another
wire is floating in the
275?
plane.
I think IVUS would be interesting if you were in the profunda and you had your antegrade axis, then you could use it. But I think
Now cards?
external
Yeah,
ultrasound is
Yeah.
very good right here.
Correct.
Still a good direction, PK. It's just that you're in a plane. You spiraled into the
This one.
into the nub.
Turn
So
it
you're
around.
just spiraling around the vessel. The vessel is like floating in
This
the
is
dissection plane.
This must be the 3.75, right? Can I see the front?
So any direction you're going, you're just going into the
Okay.
all different planes.
All right. So can I get the NTR, please?
Oh, there's just a wire. Okay. So they
It's not an option in this case, but in cases where
Yeah, the bigger one. Can I get a
this-
Sparta
this is
you
the
can come up and over. Sometimes
I need the
if
bigger one
if
for
I'm
the-
able to cross part of the lesion from above, and I know I'm intraluminal, then you can balloon up to the
No, they
area
only
through the
have one.
channel and
Yep.
then cross at a lower area where hopefully you
Spartacore?
popped open the lumen.
Were we
With
able
the
to
balloon.
find the other wire that I wanted or no?
Here, obviously, it's very limited.
Okay, call Kurt, please. So I don't know if you go through this, Ajit. It's like right now we only have 180. We need the other one. Yeah. So let's get Kurt and ask him where the wires are, please. Yeah, just ask him. So we're gonna go now, Ajit, with this, and we're gonna take this anterior catheter like we did live with the ultrasound and take it. I'm gonna park it right there for now. I'm gonna walk this out, Flora. Okay, just gonna leave it a little below the lesion. Okay. So these are some of the only thing that we could do here is probably do a cut down, and then that's another thing with a hybrid approach.
Yeah.
We could do a cut down and then externalize the wire if we don't get in with an NTR. But obviously we're not prepared to do that at
Or
this
you can
stage.
do a-
what about
Talking about
or you can do
talking
outside,
about
okay.
hybrid approaches.
If
The
NTR
other
doesn't
thing I
reach,
was
you can do an outside.
thinking about is if someone had a very hostile groin, for example, and had this similar occlusion, you could do a potentially above knee pop, cut down, and then try to cross
Right.
retrograde.
Right.
it's not something that's done very common, but in
But-
that
but-
scenario, that would be an option.
But I think
Yeah,
over
wire.
here, the beauty is we've been able to, you got it?
Yeah.
We've been able to get all the way there, right? Since we're all the way there,
Right.
watch it, fix the wire, please. Don't let it go forward. So the idea here
BK,
is
how
we wanna
about
protect-
how about before we talk about like hybrid and cut down, how about doing an alternative strategy where you get a radial access, put your sheet down, you put the wire from the top, and try to do your cart, reverse cart to see if that, and then you can snare it. Still work pedal, but at least you know you're lumen to lumen, and then you can work it that way.
That's a brilliant
that's-
idea too. That's a brilliant idea too. So can I get inflate this, please? So let's try the interior, and then I'll have Raman prep the radial, and we'll go from the radial. Can I have the inflation
And it
device?
looks like there was based on the initial angiogram, there was a nub in the SFA antigram.
Right.
So that may help you get in. And then I like Ajit's idea about, getting in a little bit, if you don't get through, ballooning and creating that separate channel that you could pop in from retrograde.
Yeah, no, that's what Vishal just said. Yeah, that makes sense. I mean, am I close there, Karthik, with the balloon?
Yeah.
Okay, I'm going to go up with the balloon here.
And I think this brings another important
give me
point
the-
of why we build up
Give
our
me the
system.
crossing wire for the interior.
Because if you do end up in a
Interior wire?
dissection plane, having a smaller profile system and just having an 018 wire versus an 035 system or even a sheath, it makes it much easier to find a different plane. So it's another reason to start with a smaller profile system.
Right. So we have the interior wire. For those of you who haven't used the interior, it's actually a catheter that has a balloon lumen with two lumens, one on either side of the balloon. So what you can do is face it on either way, and then Karthik is going to identify where the interior is. It should be at the nub right in there, Karthik? Is it at the SFA nub?
Yeah. Right on the nub.
It's right at the nub.
Can you show us the ultrasound, please?
Can I get a torquer here? So that's not it. So I need
So
to
that's your
find.
balloon right there, the thick catheter-based balloon.
Now I
And you
should
see
be
the
there.
wire coming out right there.
Am I good?
Um,
Can I poke?
no.
Can we put the ultrasound image up, please?
Can I poke or no?
Can you put the ultrasound image? Yeah.
Can I poke? Okay. So I'm going to poke here as soon as I get the torquer in. So am I up against the nub there?
You're up against the nub.
BK, can we see the balloon section?
There
on
you
the-
go.
on
Now
the
we
floor?
crossed. We just crossed.
See? That's
Everybody
it.
saw it? So we
Yeah.
just crossed from below.
just-
Save that.
Yep.
Just save that. So I think this is so I think that this is.
You're in. You don't have to even pick
Yeah,
pictures. I can see it clearly on your
I know, but let's,
The wire is
for
like
old
floating.
guys like me, you know what I mean? You young guys are different. I'm an
Sorry,
old guy. So I just want to make sure that I have a little flow here. I guess the old guy doesn't, because we didn't inject anything.
It's fine. You're in the
Hold
vessel.
on, let me inject
The wire
now.
is like floating in the vessel. So
I just want to make sure. Oh, why is it leaking, guys? Okay, we're in the vessel. Everybody
Yeah,
sees it?
definitely in.
But the question is, where did we enter in the vessel? Look where we are.
Yeah. So you entered into the proximal part of the nub.
But we're in the common
But
femoral. I
definitely-
mean, we're in the nub.
Absolutely,
Okay,
100%.
good. Fantastic. So that's, see,
100%.
guys, I think this is excellent what Karthik is making. See, angiographically, it looks like I entered in the crux.
Yeah.
But Karthik is assuring me that I'm in the proximal
if you-
part of the nub.
So if you see the ultrasound right there, right?
Right.
So that's your common femoral.
Uh-huh.
So if you come in, it bifurcates right there.
Uh-huh.
See, your wire entered right at the ostium of that SFA.
Good.
So you
Yeah.
don't see
Okay.
the profunda
Very
getting
clear.
involved at all.
Excellent. So now we're going to just move this up.
You didn't enter before.
He did not enter profunda. That's what
Nope.
that's what he just demonstrated, which is
Yep.
very good.
Right at
So
the
now,
ostium
guys,
of the
this is
SFA.
the key here when you use the anterior. I don't know how many people have used the anterior. So when you use the anterior, what you need to do is really be careful of this wire because it's a very sharp wire. So I'm going to try to just.
No.
I don't know where this wire is.
That's probably making a bend, right?
Okay, so we're going to stop it here. I'm going to walk this back. What's the wire?
Yeah.
So we don't want to Flora, please. I definitely don't want to lose the wire here. So I'm just going to go ahead, just keep the wire proximal even right here. Now we're going to ask Raman to get the 018 Trailblazer ready. And then what we're going to do is switch the Trailblazer in. And then we're going to do a balloon angioplasty with an 01440 long balloon. 01440 long balloon, okay? What longest you got? Okay, 200 is fine. So I guess you're comfortable that we're not in the crux with that ultrasound, right?
Yeah,
Okay.
in the ultrasound you can see.
Okay.
Just yeah, very proximal SFA.
So now we're going to change this to a Spartacle wire with a big loop. We're going to put it in the aorta. Now, Vishal, I got to tell you that idea that you came up with is phenomenal. And I think also Ajit about using the radial axis. And I think people have to think like that. But in this case, I could tell you, Flora, please. I could tell you, Flora?
Yeah, I'm fluorine.
Okay, I'm sorry, go. So I could tell you in this case, getting through that stent in this area, I would just stay there, Karthik. Just stay there. I don't want to see the wire move. Getting through that stent and migrating the catheter all the way down is going to be a real bear. So I would much rather work from below if I can. Good. Now you're in the vessel. Now let's give it a little dye to confirm, so we're not being cocky. Let's give a little dye. And I think this is the key now. So any comments, guys, on what you think?
I think that's a good demonstration of how to avoid the profunda, still be intraluminal, and just try to get access and do the right thing. So
I think it's an incredible demonstration of the use of ultrasound in the common femoral. I really do. Okay. Okay. Is it in the vein?
Yeah, no, artery.
You see how it went up?
Definitely artery. It's so difficult to push.
it's clearing.
I don't know, guys. You got into the vein once. I mean, I'm an angio guy. You guys are ultrasound guys. So, being an angio guy, I only see angios. Atul, are we in the artery or the vein, buddy?
You're trying to say Atul. Why are you asking Atul? Atul is also an ultrasound guy.
He loves ultrasound. All right, good. Let's get it into the... Well, this will tell us. If it goes to the IVC, we'll know. Nope. Karthik is right as always. Did I really say that twice in one day?
Yeah, I know, right? Twice in one day.
Yeah, please don't say it again.
But
all right, let's go. Let's balloon it. So let's balloon this, and then
I'll probably try to get more length on the
Yeah. It's
I
just
think that's fine. Just push
no
it up.
support.
No. Yeah, there's no support
because of the bend. You want to hold the
For this, guys? Yeah, that's good. There you go. Just walk it out now. Yeah. Fantastic. Let's not put it in a mesenteric, please. There you go. Oops. What?
Renals?
I don't know what that was.
That's probably one of the branches. It's okay.
A pedal to a coronary first time.
Probably she has a thoracic artery aneurysm also.
Okay, just leave it below that. Walk it out.
That's a real revolution, Vishal.
Okay.
Pedal to coronary.
Pedal to
Yep.
coronary.
Safe.
So Ajit, now what our plan is going to be is to do a
Vishal is
balloon
trying to give ideas
angioplasty
to
with a
the pedal
DCB after we create a plane. And then what we're going to do is we're going to go ahead and put supera in the reversal technique from below. I pull the wire out.
Okay.
Let's see. I can't
why'd
blame
you
Vishal right now. Okay.
Why Superior? Any?
Well,
other
that's what I was
reason?
asking because everybody talks. So there's a technique, as you know, they invented or they described of putting supera from below. And to me, I don't see the value of supera in the ostium because I think the crush resistance and all that is going to be for the level of the flora. Can I have the flora? Yeah. Let me have the flora.
Go.
Yep.
You have.
Well, don't pull, please. Okay. All right. So we're gonna go this. So Vishal, what's your thoughts and Atul about supera from above, from below for the ostium?
I don't know, Atul, do you want to take that?
I don't see a real advantage. I think I like balloon expandable.
Do you say?
At the ostium, I think that's smart. I usually reserve supera for my adductor canal and popliteals. I don't see a big advantage in that proximal ostial SFA.
Yeah, I think I agree. I mean, with the limited exposure and experience, I think the balloon even self-expanding, balloon expandable, drug-eluting stent should suffice and give you more patency rate as well.
Are you guys sure?
Yeah.
I am positive.
Okay. So I'm going to go forward a little
I'm
bit.
positive.
Yeah, I think here you have your choice of stent.
Okay, let's go up
Certainly,
here.
I think you could use Superior, but I think you can use other self-expanding.
Now, you guys are
stents and-
positive that we're not in the
Under here.
profunda.
I think PK from putting my angiographic hat on, I think
can
you
balloon
can
and
just take the LAO. And I think that's what it is. We're constantly doing RAO pictures. It looks like maybe an LAO or something different.
We
angle
did.
to show you.
Extreme LAO.
No, we did do an LAO. We did do an LAO. There's a lot of overlap.
Overlap, yeah. LAO is going to be, we have to go
LAO is
extreme
pretty much-
RAO.
Well, this is as extreme as you get in a coronary room, so we're going to have to deal with it. Go up.
Hold on. You can't be in the profunda. It's impossible.
12.
Anterior cannot go into profunda.
14.
It's impossible. If it was out back, we can actually think about it.
Okay. Down.
Thank you.
Down.
Yeah, the
Okay, now
profunda
let's walk
calcification
it
is at
back.
the other end right now. So you can see
No,
the
walk it back to here. So we're going to balloon distal, and then we're going to take a picture. Okay, go up here.
You know, what are your thoughts on using? I mean, in this case, obviously there was a dissection plane, so I wouldn't. But on using atherectomy from below.
We could. I mean, I still can. I still think we
Yeah.
should use an atherectomy, but I don't know what it's going to add because we're going to stent all this anyway. So why bother? So I think I'm just going to use a drug-coated balloon
Yep.
or a drug-eluting stent, depending on how it elongates. So that's a great question here, Atul and everybody. What do you guys think? Should we just go with primary Zilver PTX here?
Yeah, I think I agree with that part. I would probably just go primary drug-coated stenting in this case and
Right there.
just be done
That's
with
common
it.
femoral.
It's just both the scaffold and the
I don't
drug.
think a balloon will hold up. So I think,
Yeah.
and I agree with you. Not going to do atherectomy.
Yeah.
I think a stent is the way
At
to
least
go.
you'll get the.
I think a scaffold with a drug, I think, works good. Sardar,
Okay.
any
Absolutely.
comments?
Down.
Agreed.
Okay, so let's get some Zilver PTXs, guys, and we'll be done in hopefully in a few. 6-0 Zilvers. Or let's IVUS. Let's get an IVUS.
Can we get
Let's
one
be-
picture? Just
Let's be
I know
really
you-
academic.
how about Karthik doing one quick angio just to demonstrate?
Yeah,
how-
I am.
We are doing it right now, brother.
I have to do
Which
what
is
you and
okay?
PK say, Vishal. I
Oh,
want to be in the program, so.
You okay?
Yeah, I do the purge. No,
Okay, we're just going to do one quick
Hold on,
picture.
1 second, 1 second. Close the
No,
patient.
no, it's right here.
Oh.
Oh, you're zeroing?
No, I got
And
no
this
purge.
is, I think, one of the limitations with primary pedal. In this case, we have access from the other side, but taking your pictures afterwards can be
Yep.
kind of challenging. If,
Well,
if
you know,
can
it's
have
been described
alternate-
that they put a catheter up and do a runoff, which I think is ridiculous. You really can't
Right.
see anything. But are we ready?
Try to inject it.
Okay. So we'll see what we're dealing with here. And there's your vessel. And it's see where we are?
Right in ostium.
Are we in the ostium?
Absolutely, 100%.
It looks like we entered right at the.
Right above it.
forget.
Yeah, we're going to have to exclude that ostium.
You can do the IVUS and see. You'll know.
Looks like we're in the profunda.
You can do the IVUS and see.
All right, let's do IVUS.
Yep.
So this will be a new type of re-entry into the profunda to distal SFA.
You cannot enter into the
I'm
profunda, it's
joking.
impossible.
Let's see. Let's get the IVUS. Walk it up.
It's anterior,
Walk
for
this up.
God's sake.
No, but I mean that's why it's. I think it's important to really be careful where we enter. And I was concerned angiographically.
Because your vessel, we created such a big plane. I think you just entered right into the
yeah.
ostium. That's what happened.
Well, we'll see when we stent it, I
we
guess.
have
But
a-
you know,
another-
The
IVUS,
vessel,
a portable IVUS.
was literally floating in the plane.
can we get an IVUS, guys?
We can't get this IVUS live, so I think we should try to get the portable IVUS. Maybe we can get that image loaded up.
All right. All right.
Anytime
So
we go over
PK, I'm
some
just
data.
a little. I just
Fine.
want to tickle your thoughts on your entry into the profunda. So you're telling me with anterior, the wire like you're in the SFA plane, your wire gets out of the SFA, goes to the tissue, enters the profunda, and gets out. Because remember, profunda dives in.
You have to understand that, you know, when you're talking about a guy who's done a lot of angioplasty like me and a few other people, me and Peter Ferries, we do amazing things. We're able to penetrate into bone, come out of bone. I mean, I'm joking. I have no idea. Angiographically, I'm not happy. I can tell you that. Okay.
Yeah. What's
Right?
the question
I
on
mean,
that
would you
stump?
agree?
Yeah. No.
I mean, angiographically, I don't think I did this happy.
You
Yeah, I
definitely
mean-
didn't go into the stump.
No, I
PK.
understand, but I'm a little
Yeah, either way,
worried.
there's
I'm a little
certainly
worried. I'm at the crux.
a big dissection there, and we're right,
Right?
at the origin.
Yeah,
so,
I'm
it's
at
not
the crux.
It would be.
Do you
Yeah,
want
we
to
don't
take
have
a
the
large
So
luxury,
balloon and
PK, let me ask Ajit, what do you think about that angiographically medial to the vessel, that stump coming down? Is it a branch? Is it collateral, or is it the SFA?
That's the SFA.
No, that's the SFA.
That's SFA.
So we are way,
One second.
I think what
way.
we're
created
seeing-
such a big plane.
I think
that-
exactly.
Yeah, we
I
just
think there's a
went
big dissection
Yeah,
there,
it's a
and
big dissection
we
plane.
entered right at the origin of the
You
SFA.
can, you can see in this picture, right? The frozen picture. See how big that plane is? Huge.
No.
It's like a Venus plane.
Yeah.
Right. So
Okay.
I guess PK's point is valid to make sure where we really entered, because once we start stenting, if we don't if you don't exclude the entry point, then then we're technically putting a stent in the subintimal plane.
No, I'm
No,
okay
that's not his
putting. That's
point.
not my point. My
That's not
point
his
is
point.
is that
Point is, did we enter into the common femoral? And when you stent, does the
Correct.
profunda shut down?
exactly.
That's what I'm trying to say.
goodness.
It's like you don't want to touch the ostium, but you also want to make sure you don't put everything. If you don't want to stent the ostium, then it defeats the whole purpose of stenting.
That's what I'm worried about, and that's
Correct.
what I'm worried about. And I'm just teasing Karthik because I mean, like Atul said so well, he's phenomenal with the ultrasound, and of course Ajit is here as well. But to me, angiographically, I'm a little uncomfortable, guys.
So
This is common femoral.
Right.
Common femoral. Chroma flow, please.
Can also we adjust the image? Can we make the diameter a little bit small?
Okay, chroma flow. Okay, diameter. Can we increase the diameter?
Just go to adjust image.
Right. I think that was a good point. So that's why we're trying to enter a little bit more proximal, I guess, more distal
increase
into
the
the
diameter,
SFA.
15.
So that way you don't enter into the CFA per se.
No, 15.
15 is okay.
That's good.
Okay, that's good.
20 is actually better. But
All right, guys, record. We got everybody here to help us.
Close it. Close that. Perfect. Okay.
Okay, on. Record. Okay, I'm going to pull back slowly. I want to see whether we see the bifurcation.
That's your bifurcation, right there, and that's your
so we
ostium.
entered
Oh,
right
and
at
I
the-
see the flap.
I'm telling you.
Yep.
No,
There's
no,
a flap.
no,
There's a flap.
No, guys.
It's a flap.
There's a flap in the
flap.
SFA.
Okay,
So
go.
which is the profunda, which is the SFA?
So go
The
forward.
you pull
SFA
back?
is on
You-
top.
you- no,
SFA is on top.
No, you're already in the SFA.
Right.
Yeah, go
Right,
forward
see
a little
that?
bit. Go forward in the bit.
No, I understand. I know how to read IVUS, dude. What I'm saying is this. What I'm asking you here is, in this situation, you have a flap right there. You see the catheters in the dissection plane.
Okay.
You have true lumen on top, and you have true lumen in the profunda on the bottom.
So if you
So
pull
when you
back
pull
to-
back,
if
you can
pull
see
back, that's your SFA.
that's your
right?
SFA. So you clearly have a septum between the two, so you're safe to stent.
Yeah.
Okay, agreed.
Yeah, for sure.
So,
I think you
Can
see
can I say it
clearly on
again?
the right.
No. Can I just say it one more time so that Sardar can record today? Karthik is right again. So
all I
Sardar,
have learned over the
how is it possible?
all I've learned over my
I
minimal
don't know.
amount of experience
Right.
is ultrasound never lies.
have
I
the,
think if you're a good ultrasound guy, most of the times you're actually right on the mark. Just like IVUS is external ultrasound for us, like for coronary, like coronary has OCT and IVUS, we have external ultrasound to guide us. Usually, if you're good with your external ultrasound, you can enter it.
And look, guys, I think that this is the kind of cases you're not going to see at live conferences because these are the cases that are very difficult to do that take about an hour and a half now. So the idea here is let's just do this. So now this part, I think we've done a lot here. So what we're going to do is we're going to change out now for an 035 wire. So give me an 035 supercore. So this way I'm going to keep the wire safe in the aorta and not so I don't have to worry about it. Okay. So I think this is very important. I'm just going to leave it right here.
No.
Okay.
Let me just get the wire up.
I don't think it's going to go.
Catheter up.
There it
One
goes.
second, one second.
Okay, good. Okay, that's good. 035 supercore. We can go up with the supercore now. Okay, supercore, guys.
Yeah.
Wire out now. So now we have a supercore. Now the question is, do we balloon a JIT or do we just direct stent?
I think if we're gonna stent anyway, then I think we can, and we've already created a little lumen there for the stent to expand. I think we can just go straight for a stent.
For a stent.
Yeah.
And let's measure the IVUS for this IVUS at the level of the SFA.
I would balloon once.
You'd
the
balloon
ostium,
once?
Yeah,
Okay.
ostium. Because we only use a 3O balloon. It's a
4O.
balloon. It's pretty small. I would probably take a 5O, 6O balloon. Just make sure because we'll keep.
Is the utility of ballooning now to create a lumen so the stent will track, or what exactly?
No. The stent
are you gonna
expansion. That's all it is. The
Just
stent
push it up?
doesn't expand. Now you are trying to balloon the level of the ostium, so you can actually tear the vessel.
Yeah.
You're trying to get a good lumen.
All right,
I guess that's
get us
an
a
option.
6O long Dorado.
Just for vessel
Yeah, or
prep,
you could
that's all it is.
post dilate too is another.
Okay, let's walk it out. So now we're going to walk it out. Now I got an 035 wire, which is safe. And I want to really just, emphasize that to everybody at home. You're working in a coronary room and you don't know what's happening in the belly. Even in a peripheral room, you won't know what's happening in the belly. The wire can easily sneak into a thoracic branch. It can sneak into a lumbar branch. I mean, these are small things, but when you're on anticoagulation, they can become big things. So it's very important to change to a safe wire and then take it from there.
Yeah.
Right? Don't you agree?
Yeah, for sure. Or mark the end of the wire if you can on the table.
On the table.
Yeah.
It's a 7O vessel.
Okay, so let's go with a 6O balloon. So this is where I think external ultrasound is going to serve us well again. I hope they didn't take it away again, because what I'm going to do is I'm going to have Karthik tell us where, and Ajit, since he's also, we're lucky to have him, tell us where the ostium is. So this way we're going to place the balloon
I'm sure Ajit
by
is better than me,
ostium.
so.
Rail, please. Okay, late rail, please.
Yes, Eluvia, yes.
Well, I mean, we'll talk about that in a second. What stent and why, and I think it'll be very.
Size.
I was thinking of that because of the size of the vessel and
Ready?
Right.
the availability of these devices.
Yes, I agree. So let's go ahead and Karthik, you want to do the external ultrasound before we go up? And Ajit, can you confirm with us?
Sure.
So, Atul, we're going to use ultrasound again, and then I'm going to do a combination of ultrasound with angiogram for us to be able to see how to place this balloon.
I
I
love
think
it.
the other way you could have done it
That's
is
the
when you
only way
do
we're
it.
going to do things these days.
I couldn't hear you, buddy.
I said I love it. I think this is the only way. This is the only way we're going to do things these days. Is a combination of angiogram.
I'm going to pull. Yep, and I'm going to pull this back, Atul, just to show Karthik, and I'm going to come into the picture. So this way, now I'm out of it, so he can identify the
option,
wire
please.
first, and then I'm going to pull the balloon in so it arrives.
I got the wire.
Okay, so I'm going to. Shall I pull the balloon in? So tell me when to stop all under ultrasound.
I would stop right there.
Okay. Okay. Atul, you're okay with that, Ajit?
Yeah, is that the tip of the balloon or is that where the
I'll do
dot
it one
is?
more. I'll do it one more time. That's the tip of the balloon, not the dot.
I see.
Yeah. Go in a little.
No, I think we should go in a little.
Go ahead. Yeah.
Can we switch off the IVIS? Can we go back to the angiogram on imaging?
We need
It's actually
ultrasound,
better.
please.
It's up.
That's good. So
Very good.
show them again, Karthik.
So you want to pull back?
Yeah, I'm gonna pull back, guys, just for those at home. Now the balloon is gonna appear into the ultrasound image in a second, and he's basically identifying the profunda and the SFA junction, and he's gonna tell me to stop so I don't go too far into the common femoral
That's your junction.
and potentially dissect the common
So
femoral.
that's your nub of the balloon.
Uh-huh.
And go in a little bit. That's a good spot. That's a good spot. That's a good spot.
Did everybody see that?
You see that thickening right there?
Yeah, right there.
This is dilute, guys. Is this enough? What length balloon is this?
Fluoro if you want. 60.
100?
600, 200.
200. We need more dye.
I think another thing you could do probably is when you're doing the IVUS, because IVUS exactly from inside can show, you can actually sinnate right at the end and put it on your marker as an outside, and you could probably balloon from the outside glow tape markers as well. So that also gives you a good idea where the profunda and the SFA really start.
That's a great point, but glow
So
tape
that's
is, as you
another
know, it's not a perfect science with glow tape, as you know. So I think that this definitely one thing which might have helped is if we didn't have a AAA graft and we have the radial, Flora, then I think the radial access would have helped. So we're just going to go up with the balloon slowly. You're going to have some pain, Lizzie. So here comes the balloon. The balloon's going up. And we're just going to see where the balloon is. There's the balloon inflating. And nominal is, guys?
The other thing you can use is bony landmarks.
Correct.
Here it's
That's what I
it's a
meant to
little
say.
Here it's a little
6
challenging because you really
atmospheres.
need to be very precise, but in other cases that's another way to do it.
Okay, 8 atmospheres. Flora? Okay, balloons up. We're good, Karthik?
Yeah, you're good.
Okay, excellent.
You're very good.
Okay, off.
Actually,
Let me see
right
now.
on the mark.
Flora, let's just see where the balloon expansion all
Yeah.
the way down now.
Yep.
Flora? So there's your balloon expansion, 60200
Okay.
at 8 atmospheres. Flora? Okay, a little bradycardic, which is good. That means we're very subintimal. And, this is the idea of good nursing as we're all very distracted here right now. Okay. Okay, balloon expanded well. Flora? I'm going to come down. Now, would you be surprised, Flora, please? Okay, would you be surprised to see that this distal vessel or that stump is still going to be up and running? Can I see the
Distal
bottom?
stump is still going to be.
Meaning the proximal stump, if after we balloon, is still going to be patent. Can you pull this here so I can see the distal?
Yeah,
balloon?
I mean it could be.
There is
There's
the distal part
a
of the balloon.
pretty significant
Show me
dissection
the
there, so I
glow
wouldn't be
tape. Where's the glow tape?
surprised. If
Where's the
without
glow
a
tape?
stent and without that radial force, that it kind of collapses
AP?
even with the balloon.
Yeah, that's what I'm asking. Yeah.
Yeah.
Flora?
Yeah. So I think I wouldn't be surprised if it's still patent.
Little lower, please. Show me the distal dot. Okay. Towards you. away from you. There you go. Okay, so that's around 7 or 8. Laura? So she made Brady again, Lizzie.
Which is why I think when we place the stent, it's really important to be very precise, so that way we can have as much radial force proximally, because
Very sensitive.
to land our stent, precisely, because I think that would be a reason for an early failure is if we don't get that proximal origin of the SFA open.
Okay. So let's take a picture after this. Should we balloon a little distal, or I think we're okay?
No, we're okay.
Okay.
Still, it's fine. You can stent and post it, no? PK? You don't have to post so many times
Okay.
and make a
Got
Brady.
it. Got it. What's better? Okay, ready, rail? Flora?
Yeah.
Flora, please. Wait, I got to go double negative. So, Ajit, I know you have interviews. Can you hang on a little bit more for the first stent and then go?
Yeah.
You.
Okay, thank you, man. No, it's huge. I know it's important. I don't want Peter to be upset with me. He usually is.
Yeah. No comment.
That went on documentation. So
Okay.
PK forgets sometimes he's on mic. So
All right. Ready? Let's take a DSA up top.
Now Ajit can feel our pain.
Oh, my goodness.
I think Vishal just got his contract, so he can say whatever he wants.
Not yet.
My contract is due for renewal, so I can't say whatever I want.
All right. Ready, guys? Let's say DSA. All right. Let's see how it looks. Yep, it's still patent.
No.
Yeah.
It's still there.
That's nice.
All right, good. Let's get a 6.0 long stent now, 6.0 long silver PTX. So guys, you can see here that what I'm going to do after we're done, just to demonstrate that everything is over, is take a pigtail up to the common femoral and inject from the common femoral. So like Dr. Rao was saying, that we do not have any excuse for an early failure. If we have an excuse for an early failure, it will be osteal occlusion or osteal dissection that we left. So I think we need to ensure that. So as much as we're doing with all this, we'll also confirm with angiogram and IVUS where we are. So let's get a 6.0 long silver. So or should we do 7, Karthik? What do you like?
7 is good.
You have 7. No, silver comes in 7 too.
Yeah, they're short
Seven
though.
is just- 7
Oh,
is
do you
very good.
have 7 long alluvia? Alluvia should be in the cart. Do we have it, Sardar?
Yeah, I think we have
Yeah.
In the cart. In the
Couple
cart,
of left,
Mick.
yeah.
Couple left over.
I'm surprised we are so close. It doesn't look extremely close.
I mean, it is what it is, right?
Yeah.
Doesn't lie.
Just,
So hopefully, once we put the first stent, I think we'll do the pigtail, and then we'll sign off for everybody's time, and we'll finish it. We should
Yeah.
finish this case.
We have some more
Yeah,
slides,
we'll
too.
finish this case. This is a very interesting case.
Yeah.
We'll finish this whole case and we'll be done.
Ajit is probably just thinking, Vishal has his contract. Karthik is not saying anything because of the contract. But I'm staying here. What happened to my contract?
What do you have? What do you have? No, we asked for a
you're
7.
gonna get
We
me in
changed our
trouble
mind.
here.
7.
That's what happens to the junior
7
guys.
long
Ajit.
alluvia. 120. So we're starting with 7s, guys. We're going to do 2 7 alluvias, 120s. And again, we're going from the bottom.
Raman, can you put the color flow ones?
The color.
you're starting
Color.
from distal, you said, or
No, proximal.
proximal?
Oh, of course, yeah. I think we should do
osteum all
proximal.
the
Yeah,
way.
definitely. Definitely.
120. Yep. Damien, can you hit color here, please? Yeah, color.
Yeah, I think this case also highlights the
Here you go.
utility of IVUS. It helps with confirming where we
Oh, sorry.
re-entered,
My fault. My bad.
helps with sizing. You can see the dissection plane very clearly. So I think
I mean,
there's a
listen.
lot of utility.
I mean, I think Atul said it best. External ultrasound is great, but when you're married with internal ultrasound and angiography, I mean, now you're adding a lot of information to help you. Right? I mean, Atul, don't you think it really helped us a lot here?
Incredible. It's almost like doing
have anything in
having CT guided, like you're doing 360 imaging, you have internal, external, you have, angiogram to help make us feel better as well. But I think in this case, the internal IVUS will be essential after you put that stent in, more so than the pigtail angiogram. I think that
I agree.
IVUS will really help us feel confident.
I agree here.
So I thought I'll put color flow just to show you the osteum, right? Where exactly it is.
I'm just going to go in this view, so get
Doesn't
Karthik
matter.
out of the way a little bit for him.
No
So what do you think here? Are we at the osteum? Or go
Back your stent. a little bit.
back my stent, back the stent up a little, Roman. So you don't need floor here, just back it up. You're backed, yeah. Back it up, Roman. More, all the way out, all the way to the SFA. Out of the plane so you can see. That's good right there. Tell me when you're ready.
Okay, now go ahead.
Okay, now I'm going to advance the stent under fluoro and as well as this, and we're going to use bony landmarks.
That's your tip of the stent, right there.
A little bit further or no?
A little bit further. That's perfect.
Okay, so Ajit, you agree?
Yeah, it looks good on
Okay.
ultrasound.
Okay, off ultrasound, I'm going to do a DSA. All right, ready? Ready, guys?
Yeah. Hold on now.
I'm going to fill up. Ajit, what's your feeling on the stent hanging into the common femoral, compromising the profunda by the struts, but not by flow?
I think I would still be pretty hesitant. I think most of the time it'll probably be okay, but the last thing you want to do is compromise your profunda because that's really the lifeline of the leg, and especially in a claudicant. So
All right, ready?
I would err on the side of being conservative.
Okay.
I think.
Got it. No?
Yep.
But I think that's an important point, though. Sometimes you do need to kind of
Now
flare
you
it
see how
out.
far up we are? That's
Yeah.
actually perfect.
That's perfect.
Look at
I
that.
told you, right? On the ultrasound.
That's
it's
perfect. Ajit, you okay with it? I think that's awesome. Now,
Yeah,
guys,
we're right at the origin.
I would probably go up a little. That's me.
I would
but
probably go up, but again, the
I mean-
ultrasound.
I
I
mean,
guess.
it's yeah, it's actually. I mean, it's probably one. Based on the ultrasound, it's one strut into the profunda.
All
all
right.
right,
probably-
let's do it.
I'll probably
All
leave
right,
it
let's
right
go.
here.
So I'm going to go live and let Karthik wants to deploy it. And we're going to deploy. Vamonos. So remember, it's going to, you
Wanna
see,
puff a little bit?
huh?
You want to puff a little?
Okay, hold on. Inject, please. Inject for me. Inject. Hit inject, please, up top.
I'll flower
Okay.
one.
Hold on. Yep, that's good. I like that. I like that a lot. Uh-huh. Inject again, Raman.
Okay.
Inject, Raman. Okay.
Can't push in further now.
I'd rather.
I would keep it right there. I mean, there's no way.
I like it. I like it. Ajit,
Yep.
it's going to elongate, so you need to watch it now. Good, you got it. Beauty.
You also have to consider that if you balloon it afterwards, it can also foreshorten
Yeah, it
and
can foreshorten
come
a
back a
little
little bit,
Yeah,
so-
that's why I said we probably might.
And you did.
Yeah, I
You
did.
did a
I
beautiful
went up
job.
one strut.
Beautiful job. All right, let's get another 7-0. Okay, walk this out.
Let me just check on ultrasound once.
PK, I really gotta go. I
Okay.
realize Ferris is gonna
Thank
kill
you,
me.
bro. Thank you. So
right.
Dr. Rao is going to leave us. Thank you, Dr. Rao. I really appreciate
Yeah,
it.
of
you,
course,
Ajay.
of
Thank
course.
you.
Thanks
It's a
for
great
inviting
case.
me.
Thank you.
Thanks for all the advice.
Of course. You guys
Thank you.
take care.
70120.
Yep.
You're not out yet.
Out of wire.
That's perfect. All right, so now we're going to go ahead and.
While we're wrapping up here on this part, just a question that I think we ask every case is our antiplatelet, anticoagulant strategy. This patient came in aspirin, Plavix, and Pletal. What are they going to leave on?
I'm open to suggestion. I know I have my thoughts, but let's start with Sardar.
I mean, since now we have an open patent vessel, we can actually
Beautiful, like
stop
perfect,
the
right?
We'll show it
platal
again.
and probably give the patient
Rail?
rivaroxaban in low dose, like for the like Compass and Voyager dose. This might be a possibility, but also keeping the patient on silostazole for a while
ahead, Roman, you
to
deploy
improve
this
her exercise capacity and walking ability would also be
I'm
a
going to
good
keep
option.
it here for you.
Can I have a new 6?
Yeah, I think I agree. I mean, I would probably
Dorado?
just switch over to aspirin,
go.
Plavix, and a low dose
Wanna
Xarelto,
go up a little?
Yeah,
Xarelto
probably one
2.5 twice daily. I mean, that's my regular PAD strategy
again.
right now,
That's
based
actually
on
good.
all the data we're coming out. And I would probably hold on to the Pletal because I have so much antiplatelet, flowing in the blood. So
Beautiful.
that's
buddy.
usually my strategy. Switch them
job.
over to low dose Xarelto.
That was a beautiful
So
stent
aspirin,
deployment
Plavix,
by Raman.
Xarelto, and how long would you continue the DAP for?
Nice.
So, yeah, I mean, Plavix usually is 3 months if drug coated. I mean, unless there's a
I think
coronary
so.
indication.
I think so.
And then keep them on aspirin and
Now
Xarelto.
put a Zepara now.
If it's a repeat offender, then I probably want to keep Plavix. You know how it is, Plavix for longer period of time if tolerated well. So
I don't know.
it all
Let's see.
depends on the presentation.
a
If it's a
DSA.
vascular
Just a little
path,
bit
repeat
more.
intervention,
so.
then
Let's
I'd
just
want to
do a
keep my
DSA.
antiplatelet for longer duration, unless
DSA,
there is
bro.
a known side effect or known whatever might happen with the use of Plavix. So same thing, off-label use, long duration to see how the patient does. So we'll see. All right, let's.
Yep, we got to send one more below. Yep.
Yeah, you need some more outflow.
So you want to do Supera? What do you guys want to do? Do you feel like we should do a Zilver?
Just do a silver.
Let's do a Zilver. Zilver PTX 60
100.
100.
Yeah, because that calcification is where you really started from, so
Yep.
you still have a little bit room to go.
You have a couple more slides if you want to go over them.
Yeah.
Yeah.
So I'm gonna have Raman just do a couple more slides while we do this, and then let's talk a little bit about the data. Go ahead, Raman.
All right, you can put this.
Go back to the slides.
All right. Just one, the biggest point here is that there's no randomized, any controlled data. That's at the end of the day, that's the biggest takeaway I think that we should be trying to take away from today. But I've included two of the biggest trials that I could find. Both of them are just the retrospective cohort studies. And the first was published in catheter cardiovascular interventions, and the second was in JACC interventions. Both of them, again, are only retrospective studies. The first thing I just wanted to talk about before is another meta-analysis that was done back in 2014 or so. That was looking at kind of what are the complications of transpedal access after reviewing about, I think, 18 or 20 or so articles that had transpedal access. And the numbers that we spoke about earlier were pretty, Sardar was spot on, talking about in the 6 to 8%, and that's pretty much was driven by the dissection, followed by perforation, embolization, and hematoma. One big point, again, is that these are all just, all these are not, randomized. There was no standardized protocol for follow-up to see what the actual complication was. It was a pick and choose. So moving to the first one was a patient that we can kind of compare to the one that we did today. It was a retrospective study, multi-center, from the PRIME registry for about 5 years in 2013 to 2018. That was looking at about 740 patients with PAD and CLI that had underwent a collective of about 1,200 endovascular interventions. And what they were comparing were patients that had primary femoral access, as our traditional up and over. 254 had dual access, and they had about 100 patients that had a primary TAMI, or transpedal arterial minimally invasive retrograde revascularization, as in the entire procedure was performed similarly to how we did today with the full revascularization from the perspective. So what we had found, what they had found was that the dual axis cohort had the highest median Rutherford classification, which is not that counterintuitive, because you would assume that patients who require multiple action sites, just how in the coronary realm, will benefit from dual axis given the amount of complexity of their disease. And they also had the lowest amount of patent tibial vessels. The TAMI cohort actually had the lowest median fluoroscopy time, procedure time, and hospital stay, as well as contrast volume. It's important to note that in this particular retrospective study at these centers where they performed the pedal axis, it was all ultrasound guided. Lastly, one of the other main takeaways was that you can kind of discern where the lesion was based off where the axis was taken. So femoral popliteal lesions were primarily femoral axis. Infrapopliteal lesions were primarily treated by TAMI, and multi-level lesions, which were both a combination of femoral popliteal and infrapopliteal, were done via dual axis. So a couple takeaways from their main data here. Very small slides, small numbers, but again, one of the big things to note is that for the TAMI procedure, the sheath size was only done by a 4 French. They did not have any 5, 6, or 7s. Only in the other axes do they have, the 5, 6, 7s, and 8s, whatever the case may be. That's one thing that is quite important. Also, the median hospital stay was also, as mentioned before, significantly lower in the TAMI. Again, speaking to the fact that, there's earlier ambulation, et cetera, et cetera. The other salient features regarding the characteristics of the lesion, as well as the treatment options, when TAMI was performed, PTA was done in 95% of the patients, and that was considered to be the definitive therapy. There were very low, very infrequently had any form of atherectomy, again, owing to the fact that they largely only had 4 French catheters, which would really only leave the CSI orbital atherectomy as your only atherectomy device. And they also then subsequently had stent placement as well. Later directional atherectomy were not nearly as common as we're seeing in the other axes. This is also a very small slide, but this is looking at the complications, and the main thing to really take away is that the complications were largely driven, again, in the retrospective study, where there was no standardized approach to calling these patients back. They had callbacks at 6 months, 1 year, et cetera, to see how the patients were doing improvements in Rutherford class and stuff like that. And only at the repeat hospitalizations, if they were deemed necessary, did they actually have any form of imaging. But the complications that were noted were, again, driven by dissection, followed by perforation. And the main thing is that the dual axis group had the highest rates of any complication. That is expected considering the fact that you have 2 axis sites. So they had the highest combined rates of perforation and dissection, but remember that they also had both axis and
Okay.
I just got a couple more. The next one was looking at the article that came from Lipstick. That was a single center study that was looking at 550 interventions of femoral popliteal and infrapopliteal CTOs. That again were only a retrospective study. About 70% of them were CTOs, and they found that in the patients that had retrograde access, they had claudications that had improved compared to before. So you had the freedom from TLR and restenosis of 74 and 67% at 1 year for claudicants, and for CLI, freedom from TLR and restenosis was 60 and 30%. But an important thing here is that the retrograde axis was only done to facilitate antegrade axis. So all the distal axis was simply for just crossing. And again, as Sardar had also mentioned, that there was no structured follow-up. This is a diagram that they had demonstrated looking at what their most predominant reaxis type was, and they actually had chosen the most likely to be the AT for their axis point, especially because of the fact of the compressibility towards the bone. And they used all forms of reentry forms such as cart, reverse cart, and serial balloon dilatation in the subintimal planes. This is again very similar data looking at the issues that were the complications, and move on for the sake of time. It's important to note that in this actual study, they were able to do more of the atherectomy as opposed to just the PTA and stenting. But again, the dissections and everything were quite low, but the patient selection was very limited over the course of the follow-up. Maybe if you take a break and we can look at the IVUS for a second.
Just 1 second. We're in the common femoral here, and I'm just going to, Karthik brought it down from the external, and I'm just going to pull back here and record, guys. Common femoral coming down, and you can see here, there's your profunda. Okay, there's your bifurcation, there's your stent. Okay, and there's your SFA. So SFA stent is well expanded all the way down, right in the ostium, and we're going to also confirm by angiogram whether we have the profunda or not. And you can see here distal to the stent. Again, Not much disease there. Still stent.
Oh,
Well expanded. There you go.
now.
So a little bit of disease, but not bad.
No.
Okay.
Okay, we just go back to the slides quickly.
Let me just do a quick DSA
Yeah,
before.
let's do a quick DSA.
So 20, make it 40 now. Let's get a good picture.
Let's
Actually,
see
you know
the
what? You know what?
angina-
I'm gonna I'm gonna put a pigtail up. Give me a pigtail, guys.
So
Yeah, you can do it.
so while they get the pigtail ready, just a couple of the
Pigtail?
retrograde techniques. They're all these are pretty much taken
Better
from
do it
the
from
coronary data. The Safari is one that we've done, kind of just the arterial flossing. So the techniques for the antegrade retrograde interventions, the Safari technique is pretty much where you have antegrade and retrograde access, and by some maneuvers, it can involve snares, it can involve balloons, but you'll have the two wires meet in the subintimal plane, and you'll externalize and then floss the retrograde and antegrade axis by externalizing the wire, and then prolonged balloon will then allow a connection between the two true lumens through the subintimal space. This has been described through just a microcatheter, has been described with the use of two balloons, described through the use of snares. But all these with the increasing uses of the devices, especially with the snares, the risk of further vessel injury increases. Cart, reverse cart. Both of them are well-known, controlled antegrade and retrograde tracking and dissection, and then the reverse of that. So if you have both antegrade and retrograde access, and you have from your antegrade for cart, I would describe, you'll have access to the proximal cap from the antegrade axis, and with the retrograde axis, you've accessed the subintimal plane, and you've inflated an appropriately sized balloon in the retrograde subintimal space. It all depends on which level you're accessing on, whether you're at the tibial, the popliteal, SFA, so the balloon choice should be appropriate. And then with this balloon as kind of directing you towards the subintimal spaces, then you're able to further your antegrade wire through the distally created retrograde subintimal space and then into the true lumen. And the reverse cart is simply just the opposite of this, where the re-entry to the true lumen is done via the retrograde approach from the antegradely created subintimal plane. It's a mouthful. Last thing we should quickly just talk about are the re-entry devices, because there are quite a few. This looks beautiful. Yeah.
All right,
We use today the anterior entry device from Medtronic. It's a 5 French compatible. It's over the wire. It's up to 018, and it has an inflatable flat balloon. It comes in both a above the knee and below the knee size. The difference being the width is either 3.75 for the above the knee or 2.75 for the below the knee. And the description that we give is entirely accurate, and it really pretends to the accuracy with this device. It's on both sides of this flat balloon there are exit ports that allow for directable steering of a wire to exit. The tip of the anterior guide wires come with a pre-made tip. It's sharp, that allows for the poking into the subintimal space, with the longest length of this poking segment up to 2.5 millimeters. The other two, the difference that the body of them is a little bit less stiff. 2.5 is the stiffest, and 1.5 are for the floppy and the medium. The next were the ones that we had. The next devices were the ones that we had spoken quite a bit about: the Outback and the Pioneer. Outback, the reentry device, is made by Cordis. It's 6 French compatible. It's over an 014 system and over the wire again. And this system has a radio opaque LT configuration that basically allows you to gain access to the true lumen via the orthogonal views. Very briefly, you approach bring the LT configuration to the cap you're trying to re-enter, and in one view you demonstrate an L. You go to 90 degrees, angle or torque the torquing device on the catheter to make a T configuration. That will, by a combination of these adjustments, you're able to then identify the true lumen, and then a 22 gauge needle is able to be extended into the true lumen up to 7 millimeters. The Pioneer is a very similar concept, except it just uses IVUS. It's an IVUS guided reentry made by Philips. It's a 6 French compatible, and it has an 014 tracking guide wire system, as well as an 014 needle entry wire. So the IVUS pretty much allows you to center at 12 o'clock the true lumen via chromoflow, and then you're able to set, based off the IVUS imaging, certain landmarks up to 7 millimeters. So you can decide how far the needle is going to extend into the true lumen, whether it be 3, 5, or 7 millimeters. Finally, the Quick Cross guide wire catheter is another 6 French system, capable up to an 035. It's an antegrade balloon-centered retrograde funneling catheter, pretty much where you'll have this device sitting at the proximal CTO segment, and low-pressure centered balloon inflation will center this device with the funnel extending to the walls, and retrograde wire is then traversed through the CTO segment from the subintimal space, and given this funneling structure, the wire is then just geared into the actual guide wire, the catheter retrieval system, and then the whole system is then externalized, and you're able to externalize your retrograde axis. And that's all.
I just want some final comments before we show our idea. So Atul, you talked about a trial, and I think that's an incredibly important concept of a trial to prove, what we all believe is a great alternative access. What would you need to see in that trial?
I think the predominant thing is the safety of the vessels. So I think you'd have to have some form of ultrasound follow-up, just like the true radial trials did. Not a symptomatic occlusion. You'd have to look at the ultrasound to demonstrate that the flow was there after. And I think that, or palpable pulses, something of that level to show that it's safe. And once safety is established, then I think all the other things we can look at as well, and then long-term durability. But I think you just need, a 4-week follow-up to demonstrate safety to start. And then obviously, I think a 6 and 12-month follow-up would be great.
Yeah, and I think that one of the inclusion criteria has to be is that we still don't know how to really study the arch very well. I think the anatomy of the arch has to be understood, what the patency of the DP, especially in claudicants. I think in CLI, Jihad and other people have really shown that you can do this as an effective technique to go ahead and revascularize. But to do it for claudication, as it is currently being done, is the issue. But Sardar, Vishal, any comments?
I mean, Dr. Kukar mentioned it quite complete. What endpoints are
we show them how to do
important
it?
for safety and efficacy? So I only concur with Dr. Kukar's suggestion.
And any concluding comments, Karthik, before I close?
No, I think that's it. I mean, I think we need the data, right? So I think that's if we, as Atul actually said it very nicely, somebody's doing it outpatient. We have to show them how. I mean, we have to show them how to do it safely by doing it in the hospital. We should be their guides, and I think it will be great.
Well, I totally agree with that. I'm not denying that at all. But I think that my point of showing this case was to show that, to really hammer home that your endpoints with claudication are not the same as your endpoints with coronary disease. And I think that's very important in that, saying that, you have a lot of other things. We still don't know, bleeding complications intuitively may be higher with up and over approach versus pedal approach. We don't know. There's no data. So you're right, and I think Atul is right. I mean, I agree with him. I think 100% bleeding complication will be almost zero in this approach. 40. But I think I'd like to see the data to be able to show it. But again, I want to thank everybody for hanging in. This is probably the longest case we've done in a long time, hour and a half to do a very complex CTO. We started at actually 2 hours, 7:30, and we finished at 9:30. I especially want to thank Dr. Ajit Rao for being here. He added so much to this particular discussion. And of course, Atul, I know, thank you very much, and Vishal and Sardar as always. And of course, Raman did a great job with an incredible presentation, which I think really highlighted, the data as well as the devices that are available. I think a couple of things just to finish up beyond the discussion of pedal or not is we discussed the utility of imaging. And I think that the home point is, in order to be able to utilize and do complex cases in a relatively quick manner, external duplex ultrasound as well as intravascular ultrasound married with angiography can really help you. Here, I'm going to show the final pictures. Before we close, you can see here in the final pictures that we took a pigtail from below. And did you guys see the ultrasound? Yes, you did, right?
Yeah, we just have to see the final pictures.
So we took whoops.
Top one.
Top one. Okay. So we took a pigtail from below and we injected, right? So this is a pigtail at the level of the common femoral. And you can see here we injected, and you can see here that even though we have that dissected stump of the SFA still present, you have excluded it pretty much with good flow, and you saw the ultrasound showing that the profunda lumen is very robust. So therefore, we have great flow in the profunda, great flow in the SFA. And then we went ahead and showed the mid-body. This is our dissected segment where Karthik felt my loop was too big, and he's probably wrong on that one. and then you can see here in the distal, you have a very good distal runoff again. I mean, as far as the above knee pop, you have a lot of disease, but no significant stenosis.
Right. Mm-hmm.
And then Karthik injected from below to show you that you have a wonderful popliteal. The trifurcation is patent. And then we did a foot shot. Again, you're not going to see flow in the PT because of the fact that you have an occlusive sheath. But look at the AT. The AT is robust. Look at the perineal is robust. The distal PT is filling via the arch, and you can see the AT gives rise to the arch. So I think that this is a great example of how we finish. Now, before we go, I want Dr. Guja and Ray and Raman to demonstrate how we do the closure of this.
So, I mean, I usually do it manually. Just hold it for like 8 minutes because patient is on Angiomax. But if they're on heparin, usually 5 to 10 minutes is absolutely okay. And then what we do is you can put any TR band. You can put a TR band. You can put pressure compression device. You can put like a big significant amount of gauze and then wrap it. That's fine. And just 2 hours and then take it out and patient can start walking.
So Raman, can you show us what we do with the TR band?
Yeah. Can we get a TR band?
Yep.
Or you want to use the Safeguard?
This is Safeguard is better because it's PT.
Yeah, Safeguard is better.
Because it's PT, Safeguard is better.
Yep.
If it's DP, then you can use a.
So the Safeguard comes in two sizes. This is the adult size. There's a pediatric size. The difference is pretty much just the amount of volume that has to go inside this little balloon here. This goes up to 40 cc's maximum.
So my only question is, are we going to be able to compress this because it's a 6 French sheath, right? 5/6
we do.
slender.
Yeah, we should be able to do it.
We should be fine.
Okay, let's
Not a
see.
problem.
Because remember, Vishal, one of the things is we don't have a bailout here.
Right.
We
No,
can't. That's why I think it's very important to demonstrate good hemostasis, and I think we need to be very careful in how we're showing this, because one of the things normally we could go up and over and balloon tamponade the posterior tibial, but here we don't have that option. Well, we could, we'd have to get DP access, go up and over the trifurcation and come back down the PT, which is ridiculous. So this is very important. And even if you had radial access, you wouldn't have enough length of balloons probably to get into the pedal. So this is going to be an issue here. So I'm just hoping that we can handle it.
Fine.
Yeah, I think it should be fine. Put a Safeguard, we put a large TR band, which is usually circumferential. I think the biggest issue with the PT closure, which you'll realize, is thin people who have a concavity behind their medial malleolus, if you're actually getting right at the level of the medial malleolus. That way, you're right, PK, the hemostasis becomes important. You have to probably do manual for like 8 to 10 minutes, and then put a large TR band so that there's actually true hemostasis of the PT. But in this patient, if there's some fat, there is cushion, so the hemostasis achieved will probably be easier.
Good.
No bleeding.
So we got no
I like
bleeding.
the combination of the manual with the device after.
Right.
I think that's for the PT.
And a pulse.
I do think the vasostat device is also quite good.
On the top.
It's
You want to just hold some manual
Yeah,
above it?
hold it manual. That's
Yep.
what it is.
So Atul, tell us about the vasostat device before we say goodbye.
So it's similar concept of the other bands in the sense that it wraps around the ankle, and it has a focal point, which you basically a plunger, which you plunge down on top of the artery. And what you do is you place it just like you do removing any sheath. You place it right on the spot
turned
where
off the
the
max,
sheath
right?
enters. And it does work very
pretty,
well
huh?
for the anterior tibial and posterior tibial. I think
Yeah.
the problems you get into in these cases is when you have edema.
Vasculate it.
And
Right,
when you have
exactly.
edematous legs and the ankles are thick, it's much harder to do it. And that's why I think I like the idea of a manual compression. 5 minutes is really 7 minutes is nothing. And then you put your device on. it also gives you confidence, because when you're in the next case, you don't want to be called out to go back and go look at that. So I like the combination, but I do like the vasostat, especially for the AT and PT.
Yeah,
It does compress very well.
That's true.
Okay.
It's a great device.
What happened?
All right.
Just waiting. All right, guys. Well, thank you again, and thanks for a great case, Vishal and Sardar. If you can close, and Atul, thank you. We'll see you next month.
All right, perfect. All right.
Nice case.
Thank you very much. Great case presentation by PK and everybody in the team. Thank you, Atul, for joining. Thank you, Dr. Rao
Sorry to
and
keep
Sardar.
yelling.
Again, a good presentation of how a complex case can be dealt in multiple strategical ways in a hybrid procedure, utilizing all the variable techniques available in the lab. Hopefully you enjoyed the case. You can leave us questions, comments on our website, ccclivecases.org. Go to the peripheral section. We'll be more than happy to communicate, respond to your answers and queries. We're going to see you next month on the 24th, 8 o'clock Eastern Standard Time from New York City, Mount Sinai. Till then, have a great week and day ahead. Goodbye.
Goodbye.